before we start, I'll just check that Dr. Naqvi has logged on. Is Nitha on the line yet? I can't see Nitha logged on, so I'll just check that. Okay, we'll just wait a couple of minutes for Nitha to log on. In fact, I might just give her a call.
Lenny, do you want me to text?
I just texted her earlier. She said she was trying to connect, so I might just pull her into the meeting from Teams. See if it works. So I've given a call via Teams. So that might work. I think we now have Dr. Nitha Naqvi online. Nitha, are you on? Can you hear us?
Hi. Can you see me? Can you hear me?
We can hear you, but we can't see you. Is your camera turned on?
I apologise. I was just in another meeting, which I thought was your meeting, and I think my camera's still on in that meeting. I have to say, I did think that meeting was a bit boring, and I thought that doesn't seem like a trainee meeting. It seems very boring. Okay, let me try again. Hold on, let's see what's happening with my camera. Yeah. I might have to. I think I'm in the other meeting. That's the reason. Hold on.
Okay. Well, we'll just wait for you to connect.
I'll just leave the other one. Can you see me now?
No.
No.
Can anyone?
Okay, I'll go to leave and rejoin.
Okay.
That's quite a frightening concept, isn't it? That you could be seeing your videos on in another meeting while you're in another meeting.
Yes. Aha, I think we have, so Nitha's back on, I think. We still can't see you, Nitha.
Can you see me now?
Nope, we can hear you.
How strange. Sure why that's happening, because I can see that my camera is on. Is it because I am in a phone call with you?
So are you connecting to this meeting via your phone?
No.
Your laptop is connected to this particular meeting?
Yes, and I can see you.
Oh, you can see me. Oh, okay.
No, I can see you clearly, and I can see there's 24 people on the call. But I answered this when you phoned me, but then I did join the link.
From your laptop?
Yeah. The link is in my calendar.
Yes, it should be on your Teams calendar. Is your phone still connected to us?
No, I'm not connected on the phone at all.
Oh, okay.
I'll try once more. Otherwise, the key thing is whether you can see the screen, isn't it?
Yes.
Okay,
Let's try once.
I'll just try once more.
Yeah. Try once more. So at the moment we have 38 people here. Okay, Nitha is connected again.
Yeah. Can you hear me but not see me?
Yeah, I can hear you but not see you. But
Yes.
don't really need
Should we just see if we can see the screen?
Yes. If you could share your screen, that would be great.
I think that's
Yes, we can switch screen.
So what can you see now?
I can see your screen. It's perfect. It's your PowerPoint, pediatric connective tissue disorders.
Okay, now I'm just going to try just one thing, which is hi.
Yes, we
Sorry,
are
this is
online.
on my phone. It's very non-ideal, so I do apologise about that. But I can't seem to.
There's feedback on your laptop.
How about now?
I think the mic's on both phones.
Good morning, everybody. Apologies, you can't see me.
Okay, that's
Right,
Dr.
okay.
Nitha Naqvi appearing very. That's Dr. Nitha Naqvi appearing very briefly on video. So if I could just introduce our first speaker, Dr. Nitha Naqvi is one of our consultant pediatric cardiologists here at the Royal Brompton Hospital. She's the lead for Aortopathy service, and among other things, Asian Woman of the Year. She's been rubbing shoulders with the famous people. If you've been on Instagram recently, you have seen her interview with Amir Khan. And if you've been on Piccadilly Circus lately, you might have seen her photo up on the big screen. So without further ado, I'll let Dr. Naqvi start her talk on the aortopathies and connective tissue disorders.
Great morning, everybody. So we're going to talk about this really exciting topic. It's something that I know all of you will come across because these children come a lot to all of our clinics, don't they? So I'm going to talk about all the things I think everybody needs to know. So we'll talk about the commonest causes of cardiomyopathy, the role of echo. We'll talk about screening, medication, surgery. I'll try and go through the commonest questions that you'll get asked in the clinic, and we'll talk a little bit about neonatal Marfan syndrome, and I hope that we'll have time for a case. But Leonie, could you tell me when I've got 10 minutes left and when I've got 5 minutes left, please?
Yeah, we'll do.
Okay, so the commonest causes, as we know, the commonest one is Marfan syndrome. Then the other important ones that we need to know about are Loeys-Dietz syndrome. Some of you may have met Bart Loeys. He's attends lots of our meetings. Then, of course, there's Ehlers-Danlos, but only the vascular type 4, not all the other types of Ehlers-Danlos. All the people who run aortopathy clinics are very keen to just have the types of Ehlers-Danlos that get aortopathy type problems, because otherwise there's loads of flexible children that we see who often have POTS type syndrome, and they require a different kind of help. Then there's familial thoracic ascending aortic aneurysm and dissection. Turner syndrome. Turner syndrome does cause aortopathy, and there are guidelines for Turner syndrome that we're going to go through later. Bicuspid aortic valve, and then those cases of aortopathy associated with repaired congenital heart disease. So this is actually my gym, and I put this up because this is an example of how aortopathy is not often the way you think. So this beautiful, lovely young lady was the receptionist at my gym. And one day I had a bit of a fracas with her because I decided I wanted to leave the gym. And if you had actually been able to see the video, you would see I'm a little bit on the tubby side, and clearly I'd not been going to the gym. So because I hadn't been going to the gym and hadn't been for ages and was paying loads of money, I asked if I could leave. And this lady gave me all the reasons why I couldn't leave. And I had a long conversation with her. And I was very unhappy, and I wasn't able to leave the gym. And then the very next day, the poor lady passed away. She'd gone swimming in that pool that I've shown you. She felt unwell, came out of the pool and died. And it turned out that she had an aortic dissection. But if you look at her, you can see that she doesn't look at all like anybody we would think would have an aortopathy. And it turned out that clearly she did have. So that's one of the reasons we've got to be alert to it all the time. So sometimes patients come to my clinic because a parent has died suddenly, and then on dissection, on the post-mortem, it's been noted that a dissection has been seen. So first of all, the child will probably first of all come to one of our PECs, one of our paediatricians with expertise, and they usually would do a screening echo for reassurance, as obviously there's always a huge amount of anxiety in the surviving parent and the rest of the family for the children. And then the child gets referred to one of our aortopathy clinics. So I've thoracic aortic aneurysm with aortic imaging, and I've put that up because this is the one that actually is the most frightening for all of us, because I don't think any of us are going to miss a really classic giant child with Marfan syndrome. It's the ones that the children that look normal are the most worrying ones, and unfortunately screening doesn't detect all of them, which is obviously why some of them get missed. So, as I said, often there's sudden death in a family member, and it's first and second degree relatives that need screening. So this is a little bit different to a lot of the cardiac conditions we have. We just screen first degree relatives and not second degree relatives, although often there's requests. So in this condition, we do actually screen first and second degree relatives. And the safest bet is to screen them annually. So this condition, familial thoracic ascending aortic aneurysm and dissection, is autosomal dominant, but only 20% are actually detected genetically at the moment. And as I said, the children and the parent look phenotypically normal, and they're very appropriate for the aortopathy clinic. And we try our best to get a genetic post-mortem, and the aortopathy clinic is run joint with a paediatric cardiologist and a minimum of a geneticist. And we try and get the family to bring all the details of the post-mortem that they can to the appointment. The next condition that's important is aortic enlargement with bicuspid aortic valve associated with dissection in Turner syndrome. So we know that people with Turner syndrome are more likely to get all types of aortic conditions. So I've said, what should the PEC do? Because as I said, the PEC will come first to the patient. So I've got here, keep calm, it's only a missing chromosome. So the most recent guidelines for what we do with Turner syndrome were brought up in the proceedings of the 2016 Cincinnati International Turner Syndrome Group. And they brought in a lot of guidelines. So they said that all babies should have a transesophageal echo, even if the fetal echo and clinical echo exam is normal. But we obviously wouldn't do that. We would do a transthoracic echo. They've said, obviously, counsel the families that they should get prompt evaluation if there's any symptoms of dissection, which would be sudden chest pain. Have to say that I have in your family and your father or your mother has it, then it tends to be less aggressive because the gene is such that the parent has been alive long enough to become an adult and have a child. The autosomal, the sporadic ones tend to be the first case in the family and tend to be much more severe, and these tend to be the ones that are going to require treatment in childhood and tend to be more severely affected. So Marfan syndrome was first described by a French paediatrician, Antoine Bernard Jean Marfan, and he first described it in 1896 with the skeletal features, and he had 4 members of a family with these abnormalities. So we know that the cardinal features are cardiovascular, they are ocular, and they're the skeletal system, and then also the skin, the lung, and the dura may also be involved. The paediatricians are very important because really often people send me patients to actually diagnose Marfan syndrome, but really as paediatric cardiologists we are looking at the aorta and the mitral valve in patients with Marfan syndrome, and the diagnosis is really by the paediatricians in conjunction with geneticists. And the diagnosis is by the Ghent nosology, and there's a lot of different features that they look at. They have major and minor criteria, and with genetics, we can usually diagnose Marfan syndrome in greater than 95% of the patients affected. The diagnosis can actually be stigmatizing. In the past, it really used to hamper career aspirations, and even now we have to give guidance on that. It can unfortunately restrict life insurance opportunities, and it can also cause psychosocial burden. So all of those things have to be noted when we're breaking this news. There's a expert panel which has devised this revised Ghent nosology, which has put more weight on the cardiovascular manifestations, which include aortic root aneurysm, and they also say ectopia lentis. These 2 things are real cardinal clinical features because these are the most important really for the patient's health. In the absence of any family history, the presence of 2 manifestations is sufficient for the unequivocal diagnosis of Marfan syndrome. If they don't have aortic root aneurysm or ectopia lentis, but they do have the genetic mutation, the FBN1 mutation, or they have a combination of quite a number of systemic manifestations, they can still get the diagnosis of Marfan syndrome. So we define aortic root dilatation as an aortic root Z value greater than or equal to 2 on the Z score. If you have a family history of having larger aortas in the family with people who don't have Marfan syndrome, then it's allowed the Z score to be actually greater than or equal to 3. The other issue is obviously the height, and they are usually greater than 3.3 standard deviations from the mean, and that's a helpful guide. And even from being a baby, they are very long. There are some who will show no features actually until adolescence, and then suddenly will shoot up and suddenly their aorta will start enlarging. So it's quite difficult with diagnosis. So Graham Stewart in Bristol has come up with a few groups of Marfan syndrome that we could think of in our clinic. There's those that are definitely not Marfan syndrome, those who possibly have Marfan syndrome. They have a 50% genetic risk and they have some features. So those children we would see intermittently at 5 years, 10 years, 13 years and 16 years for Marfan screening. There's those who probably have Marfan syndrome who we would treat as Marfan syndrome, and then there's the ones who definitely have Marfan syndrome who are genetically confirmed. So we have all of these appearing in our clinics. As you all remember from medical school, they're really tall, aren't they? And their arm span exceeds their height span, and that's something we can very quickly do in the clinic just by getting them to stand up. All of you remember doing this at medical school. I don't know if you all want to do it on yourself quickly to check that you don't have Marfan syndrome. There's the thumb sign in panel A where you can see when you do that your thumb is sticking out. Then there's the wrist sign where you can put your thumb and your first finger around your wrist and they can overlap. So those are easy, quick things to do in the clinic. They're really flexible and they have their party tricks that the children are often really proud of, that they can pull their thumbs right back. And they often have very lax tissue. And these are things that I've always very quickly get anybody I'm considering it as a diagnosis to do in the clinic. This person's actually got very dramatic connective tissue laxity. The other thing that they get a lot of is striae. So I always ask, do you have a lot of stretch marks to the adolescents? And they're always very surprised that I ask that and say, yes, we have loads. And then I explain why that's happened. And they have high arch palate. They can have pectus, and pectus is such a problem for young people these days, much more than in the past. And the reason is everything, as we know, is all about social media, taking lots of photos of yourself. Appearance is extra important for our young generation. And this can be very much a problem, especially for boys. With the girls, it upsets them a lot, but when they get breast development, it tends to be less obvious. There is a treatment, the NUS bar, which some centres do and some centres don't. It was very much in vogue when I was a trainee, and we used to always have 2 or 3 patients on our cardiac ward at Great Ormond Street having a NUS bar, and I believe that's not the case anymore. One of the issues is obviously if you put the cosmetically, it gives a good result, doesn't it? And if you look at that picture there, that gentleman, I'm sure, is really pleased with his cosmetic result. From our point of view, obviously, if you suddenly have a dissection and you've got a NUS bar in there, it makes doing an operation take a little bit longer in an emergency situation. The eyes are really important. Ectopia lentes, I'm not sure if you remember from medical school what that is, but that is supratemporal dislocation of the lens. We can see it very dramatically there. And I have to say that my Marfan syndrome children, especially the ones who are the first in the family, I think all of them have ended up with this problem. And they also get lens subluxation as well. So they all must be under an ophthalmologist. This, as I said, dislocation of the lens occurs in 73% of affected people with Marfan syndrome, and the majority before 10 years of age. That really is nearly all of them, isn't it? Retinal detachment occurs in 36% and glaucoma in 15%. Cardiovascular disease mainly affects the aortic root, and aortic dissection is the leading cause of mortality in Marfan syndrome, and that it has a high morbidity and early mortality, as we know. Here we've got chest pain in an adolescent or young person with Marfan syndrome or Loeys-Dietz or Ehlers-Danlos type 4. What should you do? And I'm sure you'll get calls about patients who have this underlying diagnosis and they get chest pain. So I would say the first and only diagnosis to consider is aortic dissection or rupture. Only when you've excluded this life-threatening condition can you think of other possibilities. I mean, it is difficult because I know all of you will be holding the bleep and getting calls from DGHs about children with chest pain multiple times a day. And it's very, very rare that there is actually any type of cardiac problem at all. But if you know the patient has Marfan syndrome or Loeys-Dietz or Ehlers-Danlos, the very safest thing is to presume it's dissection. And it does, of course, mean we end up over investigating these children, but it is actually important for the children themselves to learn what is normal chest pain that they shouldn't worry about and what is a serious problem, because you can imagine they've been told that they're at risk of aortic dissection. We know all children get pains from time to time, and we don't want them, when they really get the dissection, to think it's something to ignore. So we have different types of dissection. We have the type A dissection, which starts in the ascending aorta, and that would be commoner in a child. And then we have a type B dissection, which starts in the descending aorta. And then we've got a little picture there of the actual pathology, and you can see there's an intimal tear, which then will go into the media. So this again is showing the different types on the DeBakey classification. So we've got the type A there, which has two types. The first one has affected the entire aorta. The second one has just remained in the ascending aorta. And then the type 3, which the Stanford group called type B, is more of a descending aorta issue. So as we know, aortic dissection is life-threatening. Untreated, the mortality is 28% within 24 hours, 50% within 48 hours, 70% within a week, and 90% within months. The commonest group to get it will be young pregnant women. So young pregnant women with any of these known aortopathies require very, very close monitoring. And they need to know that it is a risk for them if they do decide to go ahead and have children. So the mechanism of the dissection is dissection and rupture of the aorta, and then as a result there's compression of the adjoining structures by the expanding aorta, and then there's ischemia caused by occlusion of branches of the aorta. So the symptoms, as we know, are chest pain. GI symptoms can be very major, shortness of breath, fainting occurs in 5%, and neurological complaints occur in 20%. So we know that dissection is rare in children, and I would say I probably come across one in a child every 3 years. And what tends to happen, though, often is that the way the child gets treated is not the way an adult gets treated, because we're just, in general, the paediatricians, all of us are less familiar with it, whereas with an adult dissection, everybody's switched on to it. If an adult presents to an A&E with these symptoms, you'll probably find they're in the CT scanner within like 20 minutes to half an hour, and everybody's very alert. And there is an aortic dissection rota, which in London, which Bart and the Brompton take part in, and there is well, I don't know with COVID what's happening, but there used to be a red phone in the A&E, which was the dissection phone, and that would go off, and there's always a dissection rota on for all parts of the country to make sure any patient with dissection is covered. And the best thing really is if a child presents with dissection that they go that way and they have surgery joint with a pediatric congenital cardiac surgeon and an adult aortic dissection surgeon who will have more experience in this syndrome. So the signs are shock. They may well have Horner's, they have vocal cord irritation or paralysis, they may get wheezing and basal creps because of pulmonary edema, their Glasgow Coma Scale may be decreased, they may have hemiplegia or paraplegia. So what do we need to know? So basically the key message from my talk is do an urgent CT scan. If it ends up normal, everybody's reassured. What often happens is the local hospital will ring up and say, well, you know, we're not that familiar with doing dissection scans on children, and we think it's better the child comes to you for a transthoracic echo or a TOE. But the gold standard is a CT scan, and I'm going to show you how helpful they are, and there's no reason to delay, and I would always put strong pressure and insist that the DGH does a CT scan. Chest X-ray and ECG may help or may not help. The ECG can be normal or it may show ischemia. The chest X-ray sometimes can be falsely reported as normal because we're not really used to looking for dissections on chest X-rays anyway. In some cases, it would show mediastinal widening of the aortic contours, we can see here. There may be a pleural effusion, there may be aortic kinking, you may be able to see tracheal or esophageal displacement or a depressed left main bronchus. Here's an echo, and here on the echo in the parasternal long axis view, this is the dissection flap here. So, I mean, we all know this is the aortic valve here, and this is the dissection flap right here. This is a TOE. TOEs are much more sensitive, and they are meant to pick up 95 to 100%, but they require a general anaesthetic, and there's going to be a delay. And as I said, CT scan is the gold standard and what is recommended. Here's a TOE showing the dissection. You can see the tear here. Now here's a CT scan, and look at this. I mean, it's really obvious, isn't it, to see here. Here's the aorta, which is looking enlarged, and here's the dissection. And this is something that you don't have to be very expert to see. This is a CT scan as well, showing the aorta moving towards the arch, and here we see the dissection tear. Here again, oh, sorry. Here again, we see the tear. There's the false space there. So what do we need to know? So it's the usual resuscitation. It's really important if somebody has a dissection to control the blood pressure, and we want to keep the systolic blood pressure around 90 to 100 and not above. And you may need to do that with SNP or intravenous labetalol. There could be a pneumothorax as well, so you want to do a PA chest x-ray, and once you know it's a dissection, obviously the child needs to be coming urgently to a CICU. Intubating a Marfan patient, is important to know, is more difficult than normal. They are higher risk. They can have cardiac and pulmonary complications, and their intubation can be more difficult, and you have to be much more careful with their necks than with other people. So we've talked about Marfan on the wider scale. On a more molecular level, the problem is in the FBN1 gene mutation. That leads to a decrease in fibrillin 1, which leads to an increase in transforming growth factor beta, which I know you'll all have done a lot about when you were training. This problem really then is going to affect all the patient's cells, and it affects their extracellular matrix. So one of these is a normal mouse, and one of them is the Marfan mouse. Normally, if we were in a room, I would ask you which one you think is the Marfan mouse and which one you think is the normal mouse, but I think it's a bit difficult when we're on the team, so you can all just have a guess yourself. Which one is the Marfan mouse? Which one is the normal mouse? Don't know if any of you've got any pet mice.
Nitha, 10 minutes.
Okay, great. Okay, so I'm going to go. So this is the Marfan mouse's heart, which lots of studies have been done on. In the first one, in A, there's a normal aorta coming off. I don't know if you can see my mouse. This is a Marfan mouse, and we can see there's a really big aorta. And this Marfan mouse has been really helpful for us to do all our drug trials. So what we know in children with Marfan syndrome regarding cardiac features is that a common feature is mitral regurgitation, and that's found in 23 to 40%. Aortic regurgitation is found in 6 to 20%. They may have a click when you examine them. The echo is going to show mitral valve prolapse in anything in between 25 and 100%, depending on which study you look at. Often they have, when people say they don't have mitral valve prolapse, it's quite subtle. So it is often there. On echo, the AR is seen, and aortic root dilatation is really often there, but it may not be there the first time you see them. But there are some cases which are actually even diagnosed in fetal life. Professor Julene Carvalho at the Brompton's got great expertise in this, and she can often diagnose it before the baby's born, seeing that the aorta is enlarged. So symptoms in children, genuine cardiac problems are actually very rare in the children. They're mainly just coming for monitoring in the clinic. Chest pain, as we know, will usually be growing type musculoskeletal pain, but it's safer to be cautious and have a low threshold for CT. Dissection is rare but not unheard of, and one of you is going to come across it every few years. Arrhythmia is more common than we previously thought about, and it's often missed. So regarding the children with Marfan syndrome, as you know, they grow really, really fast. So they're very, very likely to have vitamin D deficiency. And often that is what's causing their musculoskeletal pain being worse than others. And that's often a cause of chest pain. So I always check that in the clinic for the patients. These are famous people with Marfan syndrome who've sadly passed away of dissection. The lady on the left wasn't known to have dissection, but she was a very famous basketball player in America, and she dropped dead on the court in a big match watched by most of the nation, and that brought up Marfan syndrome into the public arena in the United States. And this gentleman is a famous actor who comes in horror movies. These are other famous people who are believed to have had Marfan syndrome. Many people believe Osama bin Laden had Marfan syndrome, and people say that's why he was extra miserable all the time. Abraham Lincoln is thought to have had Marfan syndrome. I don't know if you know who this is. This is Queen Mary, the Queen of the Scots. This is Tutankhamun, who's believed to have had Marfan syndrome. That's why he died early. This is a very famous violinist. I think he's called Figolili, but I think I might have got that wrong. And this is a famous American actor who came in lots of horror movies. Okay, let's talk very quickly about Loeys-Dietz. So this is, oh, I know I put this up. If you Google Loeys-Dietz, the first picture that comes up is my photo, which is very alarming. And I certainly don't have Loeys-Dietz syndrome. This boy here has Loeys-Dietz syndrome. So they are dysmorphic, but it's not like that obvious. I mean, that guy's a bit obvious because his teeth are not looking so good, and his haircut is showing his ears, but it's not always that obvious. This is Bart Loeys and Professor Dietz, who've so lucky they've got the syndrome named after them. There's a problem with the TGF-BR1 gene, BR2 gene, the SMAD3 gene, the TGF-B2 and B3 genes, and the SMAD2 genes. And the SMAD genes ones are often more severely affected. So there's 5 genes involved. It affects the functions of the body cells during growth and development. And again, it affects the extracellular matrix, the intricate lattice of proteins and the other molecules that form the spaces between the cells, and it's important for tissue strength and repair. Gosh. Right, so these are people with Loeys-Dietz syndrome, and as I said, I think it's not very obvious. That gentleman has got like a small neck, a small chin there. You can see he's got micronathia. This little girl from the front looks normal to me. The hands and the feet are more subtle, and we're not really used to taking people's socks off in the clinic, are we? These 2 boys and this girl look totally normal to me. This guy, I'm sure I see him on the street. He looks normal to me. So I think this is why we need our expert geneticist to help us with that. So Loeys-Dietz syndrome, they get aneurysms, tortuosity and dissections, craniosynostosis, scoliosis, clubfoot, pes planus, osteoarthritis. Sadly, they also get premature cancer. So the outlook really is difficult for these patients. They often have hernias. Bifid uvula is a really quick thing we can look at in the clinic, and I have actually found this is really common in the Loeys-Dietz patients. It's really easy for us to see. Hypertelorism, they often get immune problems with food allergy, inflammatory bowel disease. I've got quite a number who have really bad Crohn's, and they have eczema as well. So these patients often can have quite a number of problems. There are some other syndromes which can cause aortopathy and overlap with Marfan syndrome. There's Spritz-Goldberg syndrome, which actually is very, very rare. And there's also Beal syndrome, where they have congenital contractures, arachnodactyly, and this is a variant of the fibrillin 2 gene. And these patients would also be in the aortopathy clinic. Regarding echo, when we're measuring the aortic measurements, we would do it usually in the parasternal long axis view, and we would measure inner edge to inner edge. And it's really the biggest measurement we are interested in, which is going to be the sinus measurement. And then you can look on parameter Z for the Z scores, and there's different ones. And most people, but not all, are using the Gautier et al. Z scores for aortopathy. Gautier-Tell ones from the American Journal of Cardiology go from 2 to 18 years. There's also, for the smaller children, Z-scores from Cantaniti-Tell for children 0 to 3 years. And I think that Great Ormond Street used the Halifax Z-scores, but those of you who work at Great Ormond Street can confirm that for me. But most people are using Gautier-Tell and Cantaniti-Tell. So as you know, there's drug trials which have actually shown that there are some drugs that may help either prevent or slow aortic root enlargement in children with Marfan syndrome. And then there's been a little bit of extrapolation to other types of aortic conditions. So the drugs that have been used in the studies are irbesartan, losartan, and atenolol. So there's been some studies comparing the two, and no effect, and the best one probably has been the AIMS trial. This is a Cochrane database review looking at all randomized controlled trials of beta blockers versus placebo or no treatment. They looked at trials that had a duration of more than 1 year, and they looked at patients of all ages and confirmed Marfan. And this is a Cochrane review that I really, really wish I'd done, and I really regret I didn't do it. But you know, these Cochrane reviews, they involve so many trials and such a lot of work. So I don't know if you know how many trials were involved in this Cochrane review. Only one trial was actually found, which is why I really wish that I'd done this review. So this is the problem. We don't have proper evidence base in children, do we? Which we all know. So in this trial, the children were the patients were aged 12 to 50, so they did have children in it. They had 70 altogether, and they randomized propranolol or no treatment. The trial did go for quite some time, and they came with no definitive conclusions, and that is like the problem with a lot of our studies. So in general, with beta blockers, the optimal age to begin them is not clear. Some investigators begin therapy at infancy. Some people wait until their aortic diameter is greater than the 95th centile, or there's a rapid rate of dilatation. Here is a Marfan mouse that I showed you before, the normal mouse, the Marfan mouse with a huge aorta, and this is the Marfan, this same Marfan mouse after treatment with losartan. So there was a lot of excitement that angiotensin receptor blockers would work because they seem to work in the Marfan mouse. And in the Marfan mouse, it was found that losartan was better than propranolol. And there were some molecular studies which showed that in theory angiotensin receptor blockers should work. Losartan is the most common one. It's a potent inhibitor of AT1 activation, hence it blocks the TGF beta activation by inhibiting TSP1 production. So there's a picture very much on a molecular level. The AIM study was the aortic irbesartan Marfan study, which was the biggest study, and I think all the UK centres were involved in that. The biggest patient group was from the Brompton, and this was, sorry, a prospective randomized placebo-controlled double-blind study of the effects of irbesartan, which is an ARB, slightly improved model as opposed to losartan, and its effects on aortic dilatation in Marfan syndrome. And what it actually showed, I'm just going to summarize it quickly because I realize I'm running out of time, was that it seemed to slow the rate of aortic root dilatation in some but not all the patients, but there was actually a significant difference in the patients who received irbesartan as opposed to those who received placebo, and as a result now losartan or irbesartan is given much more to children with Marfan syndrome, but there is no definite study that it's efficacious in the other causes of aortopathy such as Turner syndrome or bicuspid aortic valve or aortopathy associated with congenital heart disease. The types of surgery that are done when people's aorta are getting larger and larger, traditionally there was the Bentel operation, and then there's also the David operation where the aortic root basically was removed and replaced with synthetic material, and these two are slight surgical variations on the theme, and obviously the coronaries have to be reimplanted, so it's not easy surgery. Loeys-Dietz and vascular type EDS I've already mentioned. The bottom line about all the drug treatments are that overall, looking at the studies, it seems that probably, and then this is looking at non-randomized studies, so non-ideal studies, probably beta blockers do work a bit, probably losartan and irbesartan do work a bit. It's difficult to know if one is better than the other, and neither is perfect, and there will be patients receiving all these drugs who are going to end up needing surgery. So the children who require surgery are rare. It's more usual that adults need surgery. But and as I said, the children who are going to require surgery on the aortic root or mitral valve will usually be the ones who are the first case in the family. But their prognosis is excellent. I've done those operations there. So the common questions that people get asked is, what is the lifespan of somebody with Marfan syndrome? So currently, at the moment, the lifespan of somebody with Marfan syndrome is believed to be 70 years of age. The lifespan of that would be a child born today. The lifespan of a normal child born today, we would hope would be nearing 100. So there is a difference. But usually when you tell parents that, they feel very reassured. We often get asked, can they exercise? And yes, they can exercise, but there are certain exercises we don't like which are more prone to dilating the aortic root. So the exercises which are more prone to dilating the aortic root are exercises which make you really strain and make your face go red and are increasing the pressure in the upper body. So things that we really don't like are the bench press, heavy weightlifting, but little children are not normally doing that. But the thing little children are often doing is monkey bars. So I don't know, like those of you who have children, or those of you who are so young you remember being a child and going to the park and doing the monkey bars where all your weight is on your arms and you go from, it's like a ladder, isn't it? And you go from one to another. That's not ideal. We often got asked, can they fly? Because obviously there is a risk of pneumothorax when they fly, but yes, they can fly. I used to always get asked, where can they buy clothes? But now with the internet, everybody can find everything in every size. Bullying and deliberate self-harm is a real problem for patients, particularly with Marfan syndrome, because they stand out so much, don't we? We often get asked, should they have more children? We get asked about job opportunities and whether they can have a GA in the DGH. So these are the exercises that are recommended. Do I have to stop now, Leonie?
Sorry, in a minute or so. If you...
A minute, okay. So I'll just, when I need, just tell me when I need to stop. So these are the exercises that are allowed, and you can see there's loads of exercises that children can do actually. And most of the boys want to play football, and most of the girls want to do everything, including football. So these are the ones that I recommend, and there's loads there, and I really recommend swimming because that helps all their joints. The ones that were contraindicated are these ones. So really, all doctors hate boxing anyway. Rugby is an issue often for young people because they want to do it. And weightlifting, a lot of people want, young adolescent boys want to do weightlifting, especially if they have Marfan syndrome, because they hope it's going to make them look less lanky. But in fact, unfortunately, they're probably going to remain slim. So these are all available on the internet, on the Marfan Trust website, showing which ones are allowed, and some are, the H ones are the ones that damage the heart, the E ones are the ones that damage the eye, and the J is the ones that damage the joints. As you can see, we all know they're really, really tall, aren't they? But we try and prevent that now. So when they're about 140 centimeters, I refer them to endocrinology, and there's ways now we can predict their final height with blood tests and wrist x-rays. And then we ask them, do you want to be 6'9"? Do you want to be 7 foot? Or do you want to be 6 foot? How tall do you and then we can arrest their growth. So the girl's growth is arrested by finding the correct time to start them on the oral contraceptive pill, which will fuse their end plates, and the boys are commenced on testosterone. So the newer children coming along shouldn't be giants unless they want to be, and some of them do want to be. So as I said, we refer them for these tests. These are people with Marfan syndrome. So this child here, this is like a really good example. So this is the older sister who is 11, and this is the younger sister who is 5. So this is how it can really be a problem, the heart. Mental health is really important to always ask about in these patients, because so many of them sadly have got issues about their body image, the Marfan syndrome children, and some of them do end up sadly trying to take their life and deliberate self-harming. This is a problem. This is a lady who has a variant of Marfan syndrome, and if you do Google Marfan syndrome, this lady's picture comes up, which is a problem for our patients, because this woman was ridiculed as being the ugliest woman in the world. And what we find is that our patients find this on the internet, and then they obviously start thinking they are the ugliest person in the world, and then all the mental health problems will be worse. So it's really important to always emphasize the positive issues. Here's obviously a girl with Marfan syndrome standing out from her friends, but we're working on that. But even with the hormone treatments, we can't stop them being the tallest when they're younger. So they'll often be like so much taller than everybody else when they're younger, and then everybody else starts catching up with them, and we can then halt it. Okay, I think, shall I stop there in case anybody has any questions?
Any burning questions from the floor?
The one thing that I didn't mention because I didn't have time was you know, about having children, just to let you know that now there is pre-implantation genetic diagnosis. So the National Centre for that for Marfan syndrome is located at Guy's Hospital, and it's kind of like a variant on IVF. So the embryos can be chosen that don't have Marfan syndrome.
Nitha, so Sam is going to talk a bit more about PIGD later as well.
Oh, right. Okay. Excellent. Excellent. Okay.
Okay. Any questions from the floor? You could either raise your hands or use the chat function. If not,
I just want to show one picture, which is if I can find it. Well, I just wanted to mention the pairs operation, because that is something that you may hear about, which is the personalized external aortic root stent, which is basically the wrap procedure where we put a wrap around the aorta, which has been pioneered at the Brompton Hospital. But that is what we are working on doing nowadays, rather than the conventional surgical operations I showed you. And basically with 3D printing, an individualized wrap is made to put around the aorta, and that means that the operation itself doesn't involve going on bypass, and recovery is much better, and the patient keeps their own aorta, and that is an ideal in theory operation, and that is gaining popularity for sure. And that's the one we tend to do with children nowadays. Okay, thank you, Leonie. Thank you very much.
Leonie, you're muted, I think.
Oh, yeah, sorry. Thank you, Nitha, for a very comprehensive overview and quick run through the aortopathies and Marfan syndrome. So we'll move on to the next talk. Dr. Jan Till is going to talk to us about channelopathies. If those who don't know Jan, she's one of our preeminent cardiologists and electrophysiologists in the country. Lead of a channelopathy service here, president of the AICC. So without further ado, I'll hand over to Dr. Till.
Hi, everybody. So can you see my slides?
Yes, we can.
Brilliant. Oh, except we're at the end of the talk rather than the beginning, which is, let me whiz back. Okay. Okay, so I'd just like to reassure Dr. Naqvi that was a fantastic talk, and even though her picture comes up, no one really would ever believe she had Loeys-Dietz, so don't worry, Nitha.
Thank you so much.
Okay, so my job this morning is to go through the cardiac channelopathies. And these are the conditions which are kind of electrical in that they leave or show very little on imaging, sometimes called the silent assassins because they leave nothing at autopsy either, and yet can cause sudden cardiac death. I put up here long QT, bidirectional VT and CPVT, Brugada syndrome. This is a short QT, very rare, and idiopathic VF. These conditions are determined by the ion channels, and in the great majority of cases, we can find mutations in the genetic makeup of the person that keys for an abnormality in one of the ion channels that dictates the heart rhythm. And we're all quite familiar with the long QT ion channels, long QT1, which is IKS, long QT2, which is determined by IKR, and then you've got the sodium channel problems, and ryanodine and Cas2 for CPVT. And this kind of demonstrates the problem. These ion channelopathies can suddenly cause unexpectedly this sudden change in rhythm. This is bidirectional VT, which can then degenerate sadly into VF with no cardiac output. And unless you're rescued from this, either by being shocked or having very good CPR until you can get somewhere, this will result in sudden death. What is extraordinary in quite a lot of these ion channelopathies is that they don't always cause sudden death when you go into this rhythm. And this is a child with long QT, and you can see this really disorganized rhythm. I guess it's torsade, but it's an extremely disorganized torsade, which then, for reasons best known to itself, because no one understands why, it regroups and goes back into sinus rhythm. And so this group of patients can very often present with syncope or collapse, as well as sudden cardiac death. So just going to talk about long QT syndrome first, because that's perhaps the one we all know about most about. This is an extreme version, a 3-year-old with bilateral sensory neural deafness. So this is the syndrome that Chevelle and Lange-Nielsen described back in 57. And you can see this extraordinarily long QT interval going all the way out here. The T waves are very bizarre in their shape, and there's T wave alternans here. One T wave up, one T wave down, one T wave up, which is a real hallmark of long QT syndrome. I put this example up. This was a child who was found to have compound heterozygote for KCNQ1 with deletions in exons 1, so quite a big change there, which caused this rather dramatic long QT. But I just wanted to highlight the fact that you can see here the computer actually measured this corrected QT at 433. And quite often when the QT is so extraordinarily long, obvious, even eyeballing it, that it's going to be longer than 433, the computer makes this mistake and gets it wrong. And this can, of course, lead to mistakes happening and the diagnosis being missed. if you really measure out this QT and correct it, it's way out here, so it's 670. So don't always believe the computer. Always have a look and measure it yourself. The biggest problem, I guess, with long QT over the years has always been how we measure the QT interval and how we correct it for rate on various modalities, and I'll come to that in a minute. Here is another child with long QT, another compound heterozygote in KCNQ1, but this particular child, even though the QT is enormously long, and again there is T-wave alternans, you can see here in this lead, the T-wave is changing one up, one down, so the axis is alternating. But this child has no deafness, and it's subsequently been realized that you can have two mutations in KCNQ1 and you're not always deaf. We don't quite know what determines deafness. There was a study by the Mayo Clinic. Mike Ackerman and his group had a look with a large number of cases, and it seemed to be that if you had a truncating variant, you were more likely to be deaf. But it seems that you need more of a protein change if it's really going to affect the IKS in your inner ear, causing deafness. So here is what we now call autosomal recessive long QT1 with no deafness, so doesn't exactly get called Javel-Lange-Nielsen syndrome, but sadly has the same prognosis in terms of risk of sudden cardiac death. So not all examples are like that, are they? And the problem we usually have in clinic really is, does this child have long QT? And the QT is more often borderline, and it can be very difficult. So I think there's general agreement around the world, and it has taken many, many years to get general agreement around the world. Most people use the tangent method of measuring the QT interval. So you take the steepest part of the downslope of your T wave, put a line down and see where it meets the baseline. So that would be the end of the T wave there. And there are many different formulas for correction, and all of these are mathematical formulas, so they don't really hold out at extremes of heart rate, and they're all have their challenges in their own way, but most people now agree we should be using Bassett's formula. And I think most people have come to the conclusion you should look in lead 2 or lead V5 and take the longest measurement that you've got there. So this was an asymptomatic 12-year-old, and her QT, we did agree with the computer, was correcting at 470, but she did turn out to have long QT1. And the problem we really have, all of us, is that there is a great deal of crossover between those people with long QT who are this curve here. So these are the people with long QT syndrome. Their QTs can be way out here, as we saw in our first examples, but equally 25% of them can be in this group with very normal looking QT-Cs. And this is the normal population, males depicted by the black line and the dotted line females. So females have a slightly longer QT interval, but you can see there are many people in this overlap zone, which is always the problem in clinic. So as a guide, there was an expert consensus document written in 2013, getting a little bit old now, so perhaps we should re-look at this. But they suggested that you could diagnose a long QT syndrome in the presence of an unequivocally pathogenic mutation. So that's a different thing, and I'm sure Tessa's going to talk a little bit about that later. But from the ECG, you need at least 2 ECGs where the QTC is over 500. in the absence of a secondary cause for QT prolongation. So there was a great deal of my working life where we were making a diagnosis of long QT syndrome in that with QTCs much less than 500. And I think we did pick some people up, but we also got the wrong diagnosis in some. So we've spent the last sort of maybe 5-6 years of changing those diagnoses around in people. So you need at least 2 ECGs with a QTC greater than 500. It can be diagnosed in the presence of a QTC between 480 and 500. If the patient has unexplained syncope, and again, in the absence of a secondary cause of QT prolongation, and you must always think about that. The morphology of the T wave is very important. So here we have an 8-year-old. They had 2 really quite disturbing episodes of syncope in the playground. It's often difficult in the playground when you get that history, isn't it? Because the playground, a lot of people are standing around talking. You don't quite know if they were running at the time or whether they were really exerting themselves. I well remember things like it being a very competitive game, and there's a bit of adrenaline and fear as well as you running around. So that's always difficult, and often there isn't a grown-up witness to tell you what actually happens. But 2 episodes of syncope in the playground, and I think what's really striking here is the shape of the T waves out here in the lateral chest leads is not right, is it? The computer made it 450, the QTC 450, and we agreed with it. But really, this shape should start raising alarm bells here. This sort of T wave inversion out in V5 and V6. So one of the ways we try to decipher whether people in this group really do have long QT or not, and I think probably the best way we have at the moment, is an exercise test. And this particular child, a pre-test, the QTC was again 450, again with an odd morphology T wave. At stage 2, as his heart rate went up, his QT interval didn't shorten. And I think you can see it's stuck out there quite long. And so corrected with Bazit's formula, it now is reading 600. And then when we went on with the exercise test, look what happens to the T waves here. They're now really challenged. Repolarization is not going well. And so this really is an obvious long QT. It's not always that obvious, and it's not always that easy to measure on an exercise test. And what we usually do is a pre-test. Pre-test sitting down, then once they've stood up, and then 1 or 2 minutes into exercise to just look to see how the T wave is behaving. And then not usually at peak exercise, but at 4 minutes recovery is thought to be a very good time to decipher whether the QT has behaved normally or not. And this particular child ended up being homozygous for a long QT1. Okay, so moving on to treatment, and these are the expert consensus guidelines again from 2013, and there are some things which are class 1, so recommended, and there are some things which are useful, and there are some which are not indicated. So the following lifestyle changes recommended in all patients with a diagnosis of long QT. So you should tell them all about QT prolonging drugs, because this is a major cause of someone with long QT having an episode. So do warn them. Sorry, there was some funny feedback there. And to be careful about correcting their electrolytes should they get a bout of diarrhea and vomiting, or if they go on some strange diet trying to lose weight. Beta blockers are recommended for patients with a diagnosis of long QT syndrome. If they're symptomatic for syncope or you've got documented VT, well, that's an easy one. But even if they're asymptomatic, we think beta blockers are useful in lessening the risk if their QTc is over 470. Left cardiac sympathetic denervation is recommended for high-risk patients. So for those, if you can't get in an implantable defibrillator for whatever reason, or they can't take beta blockers, and ICD is recommended for patients who are surviving a cardiac arrest. Beta blockers can be useful in patients with a diagnosis of long QT who are asymptomatic and the QT is within normal limits. So that's not a class 1 recommendation, but I always discuss this with patients because it will decrease their risk by a factor of over 10. And I'm going to leave these for you to read. The one here, there was this vogue really. People felt that beta blockers were less likely to work in long QT3 and were putting in ICDs in asymptomatic patients with long QT syndrome. So this is really not indicated. There are certain things that aren't covered, though, in those guidelines. I think will be in the next version. This is a 10-year-old young man. He was known to have long QT2, and he was quite well controlled on Nadolol, and he'd been well controlled for many years. I don't know what suddenly upset the situation, which is always quite unnerving for us and the patients. It wasn't that he stopped his Nadolol in any way. He didn't take any other drugs, so he wasn't doing anything peculiar. And he had an episode of, suddenly had an episode of torsade when he was syncopal with it. They rang me. I asked them to increase their Nadolol, but was very wary because sometimes when you get an attack like this, out of the blue, it goes on into another attack, and indeed that's exactly what he did, and he went into a VT storm. He was out in Oxford, so apart from his Nadolol, we then got him into his local hospital into the John Radcliffe. He had IV magnesium, IV esmolol up on drip. But when he arrived with us, he was still very unstable. And you can see this is his rhythm from the PICU trace. He was doing several extra beats, and then there would be a pause, a sinus beat, another extra beat, looking as though it's going to start VF or torsade because it lands within that very long T wave. And it's this kind of long, short sequence, this irregularity that is very difficult in these patients because it does indeed then start an episode. And so what we did with him, because he remained having this despite all of this therapy, was to go down to the cath lab and to pace him so that we could stabilize this rhythm. And thereafter, he didn't have any further episodes because temporary pacing wise such a faff actually, and we could see he was heading towards a defibrillator. We put in a permanent defib for him as an emergency in the cath lab. This is a 3-year-old girl with a very complicated family history. This is the 3-year-old here. When she first arrived with us, we knew she'd lost her sibling at 9 days of age to a sudden death. And this was her mum who came with her. And her mum gave the story that mum's sister had died at the age of 28. And mum's sister had previously been married to the man that she was now married to, which is a common sort of thing to do in their culture. And then he sadly died at the age of 38. So a disastrous thing from a genetic point of view. And this poor lady had already lost one son. She had an existing daughter alive. So you can see here what's actually happened. Many of these people, and there's a marriage up here and then another marriage down here, which is not good, are carrying KCNH2. And so this child was homozygous for KCNH2. She'd had a defib put in, which was a rather odd arrangement in her own country. This is a defibrillator coil and an epicardial pacing system. And they'd put this in because she was so little at the time. And although it looks a bit odd, it worked. When she came to us, we did a left cardiac sympathetic denervation, and we also tried to stabilize her on some other drugs. So I added in spironolactone and magnesium. I think oral magnesium doesn't work terribly well, to be honest, but we were a bit desperate in this child, so we added in oral magnesium. Spironolactone is very useful in long QT2 because it can maintain your potassium at a good level, and that's very important. And then we also added in flecainide, which again, slightly controversial at the time, but did seem to stabilize her. And she returned back to us when she was 7 years of age with the question, could we do anything else really to get her off this huge amount of medication that she was taking? And what we did, we could see she was having VT from her defibrillator trace. And if you can see here, here we are having an episode and then it stops, probably a sinus beat, and then it restarts again. And you could see that the VVI pacemaker that she had in was allowing these short, long episodes, which were creating a substrate for more episodes of VT. And so what we did was we upgraded her to a DDD system and paced her atrium, and that completely stopped her episodes. And we've been able to wean her from her flecainide, spironolactone and magnesium. So she's now just taking a beta blocker with a DDD defibrillator in with atrial pacing at 90. And she's not had another episode. So hugely helpful atrial pacing in some of these children. And I think it really needs to be added into the guidelines. This is long QT3, and of course this is a sodium channel problem, and it is slightly different. These people characteristically get their episodes at night in their sleep, and therefore, as you can imagine, there is a great worry that beta blockers will not really be as useful in these patients. And this is the group that around the world, many people were just going straight for a defib in. With all its attendant problems. So there was a huge search out for other therapies in long QT3, and happily a number have been suggested. Ranolazine is one, but this is mixilotine. And these guidelines suggest that you try out mixilotine. As you know, that's a sort of oral form of lignocaine, so you can either do a lignocaine test or an oral mixilotine test. And if that shortens the QT interval, then it's likely to work. This is a woman actually in her 30s. She has a heart rate of 43. She's got a QTC, which we agreed with the computer at 510. Pre-mixilotine and then post-mixilotine, her QTC is really shortened. And it did make her quite bradycardic. So we had to adjust the dose before we got it right, but it can be very successful in long QT3 patients, and has subsequently been shown to be of use in long QT2. So mixilotine is a very promising drug. I'm going to move on in the interest of time, and Leonie, do stop me if I'm running over.
10 minutes.
So the big thing is, can you play sport with long QT? And that was very controversial. So when I first started with long QT, it was, no, you can't do anything. And this has been a huge drive from Mike Ackerman and the Mayo group, who have looked to see, is there any evidence really that we should be stopping these people from playing sport? And he did this study looking at 350 long QT patients, of long QT 1 to 3, Several of them had multiple mutations, and he found actually that not many of them actually had, a group of them, 130, continue playing competitive sport, and not many of them actually had any episodes. So what they are doing, and I think the rest of the world has followed, is really a comprehensive evaluation of the patient, making sure you've got them on the right treatment for what they've got, and then counselling them and making sure there are precautions in place at the ground where they're going to play, or at the stadium where they're going to play. But then it's almost a contract between you and the family and the patient to allow them to play. And that seems to be working very well, unless, of course, you encounter this situation, and I really haven't got time to show this, but this man, of course, there's no accounting for, and he did, despite on a tour, decided to play rugby with this little tiny guy here who's going in manfully, and Boris just wipes him out. So non-QT sort of safe to play, but if you encounter someone like Boris, then maybe not. We now know that there are 17 different types of long QT, and the great majority, happily for all of us, are in long QT 1 to 3, and these are the ones we know most about. And then you've got these others with different syndromes, which are vanishingly rare. So these types, and this family came to us a couple of years ago now, I guess. This was a 42-year-old woman. She had a VF arrest. She thought she heard burglars in the night and got up and had a VF arrest. She was on sotalol, quite a big dose of sotalol, for very early onset AF. Her AF started when she was 29. Her QTC was 480. So our immediate thoughts was, oh my, well, this is sotalol. This is an acquired long QT. We just need to stop her sotalol. But then it occurred to us that not only did she have early onset AF, but her brother had early onset AF, this man over here. And so we approached Tessa, our geneticist, and said, I think there's something odd going on in this family, and we really need to have a look at their genetics. And sadly, while we were doing that, the 11-year-old nephew, who had been very fit and well, so the brother's son here, had a VF arrest in the swimming pool. And went into Great Ormond Street, and Juan and Luke and colleagues could see that he indeed had a long QT. And this turned out to be one of the rarer forms of long QT, a CACN1C gene, which affects the L-type calcium channel. The other rarer types of long QT are the calmodulinopathies, and calmodulin is a ubiquitous multifunctional calcium binding protein, so lots of different effects in the body. And if there is a problem in your calmodulin, it can give you quite a severe long QT, or indeed a CPVT. It's known for causing functional block, so that 2-to-1 functional block that you sometimes see in small children presenting with long QT. And you can see that it is a higher risk than other forms of long QT. I'm going to skip over that actually, because I think we're running out of time.
Probably 5 more minutes, Jen.
Okay, so I'm supposed to cover CPVT and Brugada in 5 minutes. So here is a very characteristic ECG of CPVT, bidirectional VT going into VF. And this arrhythmia, if you see it, is almost pathognomonic of CPVT. You can get it in digoxin toxicity. The gold standard test for CPVT is the exercise test, and unless you do one of these, you won't see it. Here is a child starting off with, sometimes there's, the QT is on the upper end of normal and they're slightly bradycardic, but that's very subtle, so you usually can't make the diagnosis on that. But as he increases his heart rate on the exercise test, he develops very characteristically these VEs that come in that then turn into bidirectional non-sustained VT. And happily, when you finish the exercise test, it will abruptly stop. So it's very reassuring if you're an SPR and you get into this situation monitoring an exercise test that stop the treadmill, get the patient off, and usually this rhythm will stop. Of course, you can see it on 24-hour tape if the person is running while they have a tape on, but we usually try and do it with the exercise test. Here are these guidelines again from 2013. How do we treat CPVT? Well, beta blockers are mandatory, and nadolol and propranolol are thought to be the two that are most effective. Since 2013, all of us have been using far more flecainide in CPVT and are delighted that it seems to work extremely well. So now I think our practice has changed from this in that, of course, we start beta blockers, but we have a very low threshold for introducing flecainide into the equation and then reducing the amount of beta blocker the patient needs to take because, as we all know, patients often hate being on a beta blocker, and this is going to be lifelong. We also have an extremely low threshold for adding in a left cardiac sympathetic denervation, and it's quite a high threshold for adding in an ICD because ICDs have been a problem with CPVT in that the pain from a shock can trigger further episodes of VF and you can get into a vicious circle. What's more, they don't seem to work very well for some of the rhythms that you get in CPVT. It's very important to give the patient lifestyle advice, and all of us spend a lot of time in clinic doing that. Very fruitfully, there's an international CPVT registry that has now started up that is giving us an awful lot of information. And one of the first papers that came out from this was really linking CPVT with neurodevelopmental disorders. And this can be a very strong link and appears to occur in 8% of cases. So these are two of our families with CPVT, and you can see this mother has a ryanodine mutation, CPVT, and sadly, most of her children, bar this one here and this one here, actually developed CPVT because they inherited the mutation, and all of these have neurodevelopmental disorders, as does mum. So really tracks with the CPVT. This was a study that we did back in 2014 when we looked at what was happening with our 13 patients with an ICD in place. And we were horrified that although most of the shocks these patients were receiving were appropriate, i.e. delivered to a VT, very few of them were actually effective. And what we worked out was that if you delivered the shock into that bidirectional VT rhythm that I showed you, it wouldn't work. And so you had to target the VF, which of course is quite difficult to do because defibrillators aren't made to do this, and so the programming can be very difficult. And that led to this idea that maybe you don't need to put an implantable defibrillator in, and because they're not terribly successful in these patients and actually can cause more problems than necessary. And so we asked the registry this question: if you were previously undiagnosed when you had your first episode, even if it was a sudden cardiac arrest, do we really need to put in a defib, or should we be just going along the lines of beta blocker flecainide and a left cardiac sympathetic denervation? And this study, I haven't got time to go all the way through it, did suggest that the ICD was not associated with an improved survival in this group. So if it's your first event, even if it's a cardiac arrest, you can go with the drug therapy and a left cardiac sympathetic denervation rather than an ICD. And those with ICDs experienced more shocks than the other group had syncope, so suggesting that there were some shocks, even though they were appropriate, were delivered unnecessarily. And some of those shocks did trigger a VT storm. And of course, then you've got all the other problems and complications of an ICD. Something I've learned from our genetic colleagues, and I'm sure they're going to speak later, that this is a long, long gene. It's one of the largest, and therefore there are polymorphisms in about 10%. So beware in CPVT of the ryanodine gene. There are many VUSs. Have I got time very quickly to do the Brugada, Leonie? I'll be quick.
Yes.
So I think you're all familiar with Brugada syndrome. You look in V1, V2, and here's a 12-year-old child of ours with a classic type 1 Brugada ECG with this ST segment elevation. It's got to be above 2 millivolts and at least one right precordial lead. Here you can see it across both V1, V2. It can be spontaneous, or it can be fever-induced, or indeed it can be drug-induced. And the major challenge for all of us at the moment around the world is to work out who is at high risk and who just carries a Brugada mutation and it doesn't really affect them. So this is Vincent Prost's work published in 2016, and again some beautiful pictures here for those of you who haven't seen a type 1. This is the child at baseline, and here is what they have when they have a fever. So a clear elevation of the ST segment. Asymptomatic children identified on family screening are very low risk, it would appear, and I think we'd all concur with that. We see many, many children because their father or mother has been given a diagnosis, and we rarely see a problem in this group. And the risk factors appear to be a spontaneous type 1. So we do a yearly ECG and of course symptoms. And so it's very important that we talk to the parents and indeed the child about possible symptoms. A simple faint may not be a simple faint, although of course it may be as well. So that is always our issue in this group of patients. This is another registry that has been set up, and this was published in Aortopathies. And you can see here, this really concurs. If you've got symptoms, then your arrhythmia-free survival is much worse. So symptoms spell out risk, as does a type 1 ECG. And the great many people who are asymptomatic sitting there just because of family screening have very few problems. They also picked out conduction abnormality. This can spell out problems and atrial arrhythmia. And I think I just wanted to finish by showing this child, which really Leonie dealt with rather than me. She was a 15-year-old competitive swimmer, came in with this rhythm, which really looks rather scary, doesn't it? But when given adenosine, you could see that there was underlying flutter waves. And so this was a sort of bundle branch block being conducted one-to-one. When the rhythm had stopped, you could see that she had quite marked sinus node problems. So there were long pauses where her sinus node didn't fire. This is her sinus node, not her AV node, because you can see when the P wave is there, it gets conducted. So these are sinus pauses. And when we atrially paced her, you could see here in V2 the Brugada, type 1 Brugada appearing. And this is the sort of child that we think presents to us with an SCN5A mutation. And it's a slightly different picture in childhood to that in adult life, where really they're looking for a VF arrest in an adult with type 1 Brugada. This is the sort of thing that seems to present in childhood, and we have to deal with. So in summary, 40% of sudden, unexpected natural deaths in young people are associated with a negative autopsy, and so fall into this channelopathy group. Increasingly, we're understanding the genetic etiology with the help of our genetic colleagues, and with that, it brings us great insight into how this all works at a cellular level, and so sort of brings up the idea of genetic therapies and other drugs that might help. And so in time, the hope is that we'll have more individualized risk assessment, lifestyle advice and therapy. Thank you.
Thank you very much, Jan, for this overview on channelopathies, particularly focusing on long QT, which is the most common thing, one of channelopathies that most will encounter. So we are just about running slightly behind, but that's okay. We've got a bit of slack in terms of timings. Any questions for Jan? You could either raise your hands. Oh, actually, I think Richard's posted a question quite early on. Is the increase in QTC measurement on standing prior to exercise test diagnostic of the condition?
Yes, well, as you probably know, which has probably caused you to ask that question, there was a few, well, I guess a year or so ago, we all took to doing the sitting and standing test because it was so much easier than organising an exercise test. And like everyone else in the world, Leonie and I started doing that. So we had people sitting and standing with an ECG. The ECG has to be done fairly quickly as you stand up. And there is a difference if you look at long QT patients versus a group of normal individuals, in that the QT doesn't correct as well on standing, particularly if you're long QT1. The problem is really when you use it for the individual patient, it's extremely difficult because there's an overlap by how much your QT can respond. So there were big, broad sort of groups of where your QT could go to. So using it in the individual patient is really not so successful. And I think I prefer the exercise test. The other problem is actually sort of getting it right. And so in the exercise test, you have to be aware that as the patient gets onto the treadmill, they will have just stood up usually because people usually put the ECG dots on while they're sitting down on a chair and then they stand them up. So if you look at the baseline QT, it might be a standing ECG. So we're not really doing it quite as much as we were. We were very enthusiastic for a while, and Sammy Ziskin wrote a super paper on it. But I think in the individual patient, it's not always easy to interpret.
Any other questions? Jen will be here later on during case discussions. So, okay. Ollie, what is the role of Ashmolean testing?
That's a very good question, isn't it? It's very controversial, I think. So in adult practice, if you think someone has potentially Brugada, and that might be because there's a family history of sudden death that's unexplained despite all the other screening going on, or it might be that their ECG looks slightly suggestive, but they've had some major symptom, or that they've had, a sudden, really good going syncope, where they've crashed down onto the floor and you're thinking this is an arrhythmic syncope. Then we will do an Ashmolean test. There's great debate around the world about false positives with Ashmolean and potentially false negatives, but it's more in the false positive arena that we worry. So that's kind of accepted practice, and that continues on. When Ashmolean was first brought in, and Ashmolean after all is a sodium blocker, it's just a drug, so there's no reason why it should be 100% sensitive or specific for diagnosing Brugada syndrome. But we were doing it in children, and then there was one or maybe even two cases that I am aware of where a negative Ashmolean in childhood then turned to be a positive Ashmolean in adult life. And I think that came along at the same time as the realization that those children that you usually see are the ones who are being sort of screened because of a family history in their parents of Brugada syndrome. So they haven't got a type 1 and they haven't usually got symptoms. They're usually asymptomatic, well children with a family history. And they are at such low risk. It's almost makes more sense to me to give them lifestyle advice and just wait and not do the adrenaline at that time. And so we've adopted doing the adrenaline when they get to about 18 or 19, when you can discuss it with them and do it then. Although I think, you know, things will change as we know more. So at the moment, we're not doing adrenaline in children, or I think some people are, and that's fine. We used to do it quite a lot, and it's relatively safe. There are problems with it, but it's relatively safe. It's just I'm not really sure it helps the parents. The times when you end up doing it is when you've got a parent who really can't live with the uncertainty, and so you're really treating the parent's anxiety, I think, more than the child. And so we will do them if that, you know, if people can't live, then without knowing, then we'll do it.
Okay, one final question, and any other questions we can leave to the break or during case discussion. Question by Laura. What is your threshold for sending a genetic test? For example, you mentioned a girl with a QTC of 470 who was asymptomatic.
Yes, so that young girl had a family history of long QT. So that wasn't my brilliant diagnosis from an ECG. That was me thinking she has a mother with long QT, therefore the chances of her having long QT are 50-50. And therefore, in that situation, with a QT sitting at 470, you would absolutely go for a genetic test. Of course, you would target the mother first and make sure you had a gene on the mother before you went for the child. So I think you consider doing genetics when you think, so you take sort of each individual situation. If you've got a family history of long QT and you can find a gene in that family, then you're very much looking at the ECGs in a different light. If I see a QT of 470 in an asymptomatic child without a family history, and she's asymptomatic, of course, we wouldn't be pursuing genetics. We would be pursuing an exercise treadmill test to see how that QT behaved, and we might do a couple of those and follow her up. We wouldn't be going down the genetic route.
Okay, great. So we're running to tea and coffee time. So what I'm going to try to do here is I've set up 6 virtual chat rooms, which all of you are going to be randomly assigned to. So we're individual groups. You can only see the people around you, which are 6 or 7 of you. Turn on your cameras, interact, speak, talk, and we'll see how that gets on. So shall we have 15 minutes break? I will start the rooms now. If it doesn't work, I'm sorry. We'll try. Let's see how it gets on. There are about 15 of you who cannot get into those chat rooms because you're not using a phone or a desktop app. I think you're connecting via the web itself. So for those who can't get in, you'll be left in the main meeting room, and you can use this as your chat room. And if you could change over to an app later on, then we'll put you into one of these chat rooms. So these chat rooms are all named after tourist attractions in London. So I thought, you know, you can't come to London, we'll bring London to you. So we'll see how it works. Hi, anyone here?
Hi, I'll turn my camera on. Hang on. Hi.
How are you?
Fine, thanks. How are you?
All right, thank you. I'm Leonie Wong. I think we've met before. One of the cardiologists over at the Brompton. Although I think you are going to come over to us at some point.
I am, yes, I am. I think they're just deciding when is the best time, I've been told. So
yes, precisely. This is slightly unusual where we have 6-month rotations. Although that would work quite well. Again, we'll see what works, because at the moment things are very much pretty much back to normal.
yeah.
So there may not be such a pressing need to cut your year short, or cut your year by half, to move you around, and that might be slightly disruptive as well.
Yeah.
So I was going to have a chat with Sadia and Vicky, and then we'll come to a conclusion. I presume either way you are okay, or is there a preference for you one way or the other?
No real preference. I had said to Sadia, like, for going to the Brompton, I would prefer to spend more than 6 months there. So if it's better to do, Ollie to stay for a full 6 months, and then for another 6 months, and then I come for a full year, then that.
It's just less disruptive for both of you. 6 months is a very short time, and you kind of almost have no time to settle in and do stuff. So yeah, I'll leave that with me. I think we're meeting fairly soon in the next few weeks. So we'll let you know fairly soon. But I suspect that shouldn't be an issue.
Okay. All right. Perfect. Thank you very much.
Do we know anyone else on this line? So I'm hopping between rooms. So just to make sure that we have I don't know, Aitor, do you know, or Dimitris? I don't know, they're still on the line. They might have popped out for coffee. So it's a bit sad you're there alone on your own. Shall I move you to a different room, just so that you get to see? They might have just popped out because they haven't responded. So why don't I move you to a different room? So you can see a few of your other. Okay, I'll sign out in a second.
Thank you.
Doing proper ACHD now because we are new trainees at B. So I have spoken to Lorna Swan and Nikki Walker, and we are doing the proper 3 months block in ACHD now.
Yeah, we do 4. Okay. That'll be my 3rd block of the year.
Yeah, so it's a minimum requirement is 3 months. So I said, you know what, I'll be 3 months here, and then I'll do a bit of EP and pulmonary hypertension after that. So yeah, as Rusty said.
Very good. Very good.
Who have we joined? Hi.
Hello.
Hello.
I thought this chat was going to be a terrible idea. Then it's nice to see some familiar faces. Actually turned out to be a really good idea.
I was like, so exciting, something new happening on Teams. Hi.
I may, however, go and make a cup of tea quickly.
Yeah.
I think I will as well.
I
I
will
think
be back.
that's it. I need to make a drink and go to the loo before it resumes.
syndromes. Jan mentioned Joel Langel-Nielsen associated with deafness. Now, Timothy syndrome, Jan talked about a CACNR1C mutation, and this is another specific mutation within CACNR1C. And as I said, there are a lot of potassium and sodium channels, but calcium and potassium channels associated with disorders of both brain and the heart. And here you can see a child with terrible long QT syndrome. They are severely autistic, and they have these funny syndactyly, and really there is nothing like this. So with long QT and these sort of hand abnormalities, you could just look for one mutation. You don't need to do anything else. I've never seen this condition, so I'm still looking out for it. So Anderson-Tawil syndrome. Now, Jan is our expert on Anderson-Tawil syndrome. It's pretty rare, but it is an easy diagnosis. These children have often periodic paralysis, so suddenly they are incredibly weak. And we had a patient recently, he died sadly from a sudden death from this condition. But as a child, he was not allowed to play football in the team because sometimes he was able to play really well, but other times he just couldn't move. And they thought he was, again, playing around, but in fact he had Anderson-Tawil syndrome. Typically, they have a small chin, they have clinodactyly and abnormal fingers and toes, and they are at risk of sudden death. And I won't give my presentation of my very interesting family with this, but anyway, we'll move on from that. Now, the aortopathy syndromes have fundamentally been covered by Dr. Naqvi. Don't forget Ehlers-Danlos syndrome type 4. These are really, 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 really serious. They have multiple aneurysms and they frequently do not dilate beforehand. So it has to be a clinical diagnosis. But if you have ruptured vessels prior to anything obvious, it is very important to pick it up. This is Loeys-Dietz syndrome, which I'm not going to take any further, but as Dr. Naqvi talked about, this bifid uvula, they have slightly small chin, hypertelorism, and down slanting palpable fissures. Now, I just want, as she has already looked at a lot of these genes, I want you to just look at this one here, the SKI gene. And this is a condition called Sprintzen-Goldberg syndrome. Now, this is, in these cases, they are really, really, really severely dysmorphic. But actually, when you look at this guy, he's not that dysmorphic. And when it was first shown, this gene, it was thought to be this really, really, really out of the way gene. But actually, there are many milder children now being described. And the real problem is these rupture aneurysms that aren't necessarily the aneurysms that you see, the large vessels. They may have splenic artery aneurysms, mesenteric artery aneurysms, just like Ehlers-Danlos type 4. So very difficult to look at those. But if you do see these subtle dysmorphic features, do not stop and think, oh, well, they're just a slightly unusual looking child. This is Ehlers-Danlos type 4, where they have these thin skin, and that is in old people, that's what you would expect, but not in a young patient. And here you have slightly pinched faces, and they're rather petite. They are not that hypermobile. They may have hypermobility of their small joints, but they're really not hypermobile, the rest of them. Now, this is the last one I'm going to talk about, Leonie, and this is really a condition that I completely missed in a patient recently on our ward. I did a fetal an exome because I thought she had some form of a mucopolysaccharidosis. She was very coarse, but in fact, the exome didn't pick this up because I didn't ask the right question, and this child had a really very nasty progressive valvular heart disease, as you would expect with a mucopolysaccharidosis, and she actually had a mutation in fibrillin 1. So don't forget geophys, which can present with these things. So when should you think of a syndrome diagnosis? Early onset, age of onset. Examine the whole of your patient. Please, please, please. There's not just a heart in your patients. They've got other organs as well. I love seeing these dysmorphic patients, so please, thrilled to see them. Intellectual disabilities, and just keeping your eyes open and intuition. I'm sorry I've gone off, but we did have a slight problem in the middle. Thank you very much indeed. I've no idea if you're all listening, because you just can't tell with this remote lecturing. It's also odd. Thank you very much.
Let me send you an applause. Thank you very much, Tessa.
I didn't get one of those.
Oh, sorry, I just found that feature. I'm finding new things about Teams every single minute. So thank you very much, Tessa, for sharing your wealth of knowledge about these genetic syndromic conditions, and I'm sure a lot of us and many of us would have come across many of these kids where we're not entirely sure whether it's related to anything at all. So I would say, the take-home message really is always think about these syndromic sort of non-cardiac features, and to involve your geneticist very early on in the process if there's any suspicion that might be the case. Any questions? Any quick questions on the chat or hands up? No, I don't see any sort of anyone. Okay, that's fine. Thank you very much, Tessa. We'll move on to the next talk, and I'd like to introduce Bethan Cowley. She's the lead nurse for our ICC service over here at the Royal Brompton Hospital in Harefield, and she's just going to take us through, again, a very important part of the multidisciplinary team, the cardiac nurse specialists. We can't live without them, so she's going to tell you exactly what they do on a day-to-day basis and the role within the team. Thank you, Bethan.
Thanks, Lenny. Can everyone hear me?
Yes, we can.
Lovely. Good. Then I hope I get an applause afterwards, Lenny, otherwise I'm resigning. Right. Hi, everyone. I hope you're having a nice day so far. I've been listening into some of the talks. They're really interesting. As ever, Tessa kind of blows my mind when she starts talking about these syndromes. So I'll probably take it down a notch or two if that's okay. So like Lenny said, my name's Bethan Cowley. I'm the lead nurse for the Inherited Cardiac Conditions service here. So why have a nurse specialist team? Well, hopefully I don't have to explain that point too much, but why so much in ICC services? Why are they important? Why can't these children be looked after in congenital heart disease clinics or just pediatric arrhythmia clinics and whatnot? Well, what we know about ICCs is that there's more than 50 currently identified. There's a combined burden in the UK of 340,000. That includes FH. But what we know about that figure is that it's grossly underestimated. And this was back in 2009. There's no newer data than this. But we figure that's the case because of the amount of underreporting when it comes to these conditions. They're different from other conditions because there are treatments and preventative care for things like sudden death. It's important to know that a positive genetic result doesn't imply immediate risk. And similarly, it doesn't imply a level of risk either with most of these conditions. And what's been demonstrated already this morning is that they can be present from utero right up until old age, but some caution should be taken when ICCs do present later on in life, particularly with things like LVH, etc. And importantly, when it comes to our involvement, things like lifestyle, employment, finances, and family planning all can be quite impacted. Well, they are impacted. So that's why specialist input is imperative when it comes to these conditions. So probably the Bible when it comes to ICC service provision is the Heart-to-Heart document, which was published in 2009 by the PHG Foundation. And it looked at the needs assessment and service review of ICC service throughout the UK. And it wasn't a great shock to see the service provision varied quite dramatically from different areas within the country, with shortcomings and significant inequities amongst those services. And it was particularly concerning because we knew that this area of medicine and healthcare was only going to explode, and boy has it since then. Another issue was the balance between cardiology and genetic consultant sessions and provisions, with services routinely being more heavy in one area than the other. So the integration of these services wasn't as good, and quite frequently you would find a cardiology team and then the genetic service would be located somewhere else. So this created some issues and problems, but in the same report, it identified the really positive role of the cardiac genetics nurse and their ability to bridge that cardiology and genomic information, and that being able to translate that information to, of course, our patients and their families. The BHF jumped all over this. So in 2006, they created the first cardiac genetics nurses. So you might come across them now as the cardiac genetics nurse, and there's still some around that are called that. They've lost the BHF tag, and I don't think the BHF now fund any more of those posts. You might have them called cardiomyopathy CNSs, inherited arrhythmias, SAD CNSs. There are a few of those. You've got your FH nurses, your aortopathy, and then there's the inherited cardiac conditions nurse specialists. What you'll often find is that the cardiac genetics nurse and the inherited cardiac conditions nurse actually vary quite a bit in terms of their remit and what they cover, with cardiac genetics nurse taking on more of the role of the genetics counsellor and chasing PMs and chasing tissue and speaking to coroners. And we do that, but for us and the ICC nurse specialist team here, it's very much the whole thing. And particularly with emphasis on the condition and how that impacts the patients and their families. The same heart-to-heart document said that the nurse specialist that's dealing with these conditions should show all of those points there on the screen. So emotional and psychological support, and being able to translate complex information to these families, act as an identified contact, and show a high degree of skill and communication. And obviously raise awareness of academic and clinical research, and also, you know, network and inform other healthcare professionals, act as a point of contact and a resource as well. So I'm whizzing through this because I'm conscious of time. So at the Brompton, we are an ICC nurse specialist team. The nurse specialist team cover 10 consultants, both paediatric and adult, within the trust here, the Brompton and Harefield. We have 2 consultant geneticists, and you've met the lovely Tessa just now. There are 11 to 12 weekly consultant-led clinics, ICC clinics, in the trust. And as you can see, we cover this broad spectrum. So cardiomyopathies, neuromuscular, inherited arrhythmia, aortopathy, and we do it from fetal to old age. What you'll often find is that we know that there are different consultants that specialise in these different areas, and within our nursing team there's no particular one nurse that identifies with one clinic. We're all trained and we all work to be able to provide service provision across all of those services. The difference here, and you'll find in most services, regional services, all ICC services are regional, is that FH stands slightly separate from the rest of inherited cardiac conditions. And that's just because management is quite significantly different, and the clinical pathways for those patients are quite different. Although we have contacts and connections, we often are pretty much separate services. So in our team here, I was the first employed dedicated ICC nurse back in 2012. And prior to that, I worked in research at the Brompton, looking at biobanking and family segregation studies with ICCs, particularly in cardiomyopathies. And from that, the need for an ICC nurse specialist came out, although there was a nurse already in position as an EP Pediatric CNS who did a lot of this of inherited arrhythmia stuff. Now, between now and then, so what, 8 years, we've now got me, who's the Band 8 lead nurse. We've got the fantastic Catherine Rennick, who's the very first nurse consultant in the country for Pediatric EP and ICC. Some of you may have come in contact with her or heard from her, or had correspondence from her. And then we've got 3 Pediatric ICC nurse specialists, a Band 6 Pediatric nurse, and then 5 ICC adult nurse specialists, and another newly appointed adult ICC. Now, obviously, we're not all full-time, so it probably looks pretty heavy. We're not all full-time. But what we're finding is that these numbers are just having to constantly grow, because the more nurse specialists you get, the more abilities and the capabilities we've got to be able to do cascade screening. And the more you cascade screen, it's like a mushroom effect. More and more people come into the service. And unfortunately, because of the nature of these conditions, it's quite difficult to discharge them. Well, thank goodness for genetic and genomic medicine, the more we're learning, we're able to do that through predictive testing. But we're still not where we want to be with that entirely. So what we're finding is that our services and elsewhere in the country and the world are just growing massively and very quickly. So this is, and I hate using this word, this is the journey of the ICC nurse specialist. And you can see in every single point of this spectrum of them and their condition, we're involved heavily, and not just the nurse specialist, everyone in the MDT. Leonie very kindly said they wouldn't be without us. Well, we certainly wouldn't be without them, and our genetics counsellors, our physiologists. Our physiology team here is just unbelievable. Which is headed by Ollie Williams. You know, we really are relying on them to be able to help us formulate a really good and strong phenotype, because without that, unfortunately, most of the times genetics isn't as useful. So to have all those people have the benefit of Tessa, and when someone presents, a child presents, and it's not just a straightforward DCM, but you notice some other systems getting involved, you know that's a cue to contact Tessa and her expertise. But certainly, like I said, we're present throughout this whole journey, and it kind of loops. So at the end of that spectrum, you see death, but you know, a lot of our referrals are on the back of a death. So that's quite often when we first meet these families. But particularly the surveillance period and the referral period is where you'll find that the CNSs are most heavily involved. So one of the major jobs, just one of them, I thought I'd touch on this because it might be of interest to you guys if you are referring to us, is that any referral to the ICC service will come via the consultants, but will then land with the ICC nurse specialist. And we have a very clear pathway on how these referrals get handled. I think a lot of people, external, worry about which consultant to send them to, you know, who specializes in which area, you know, but you really try not to worry about that too much, because when it does come to the ICC team, the nurse specialists will look at that and triage that referral. One, decide the urgency of that. We've got quite clear criteria. So quite often that would be a clinical criteria if we know that a child is maybe just been diagnosed with long QT syndrome, but not on any therapy. If there's been a recent sudden death in the family, that would be our cue more for a psychological point of view to see that family quite quickly. Or if we know that somebody's a child having frequent syncope or any kind of unexplained syncope within the context of a history of family, a family history of sudden death or an inherited cardiac condition, we will get those children in and adults in very, very quickly. And then what we do is, based on what we're seeing, is we will decide which clinic they go in. And you can see there, we've got quite a few clinics. We've got our inherited arrhythmias, we've got our aortopathies, we've got our cardiomyopathies, we've got pediatrics, we've got the adults, and we've got some family clinics as well. We know that within cardiomyopathy, if I've got a good going LVH with horrible outflow tract obstruction, I will know that patient should probably go in a certain consultant's clinic who specializes in the myectomy program. Similarly, if a child presents with maybe a family history of ACM, which is pretty rare, but we would have the inherited arrhythmia team, Leonie and Jan, see those patients, because we know that the problems with ACM in childhood is going to be arrhythmia focused. You know, if somebody presents, an adult presents with a family history of ACM, we will often then plug them in to the adult ACM service, because we know that the issues will be slightly different. So we think about a lot. We then think about family history, and we do a lot of, we act as like Miss Marples, to be honest, connecting all the dots, and we do that very much so with our GC colleagues, our genetic counselling colleagues, who will then contact them for family histories. But we will also call them as well if we are concerned, to get more of an assessment on their symptoms, if there's any red flags that we're seeing. And then based on what we see, we then think about what investigations they should have as part of a workup and a risk stratification before they're being seen. And we have I've just snippeted an example of there, but we have a very clear table of investigations. But, you know, that is a guide. We still use our critical thinking with regards to that, but that covers both pediatric, adult, inherited arrhythmia, cardiomyopathies and aortopathies too. And that system then goes to our ICC admin team. Things get booked in, and then we see them. But quite often patients will receive a call either from the ICC nurse specialists or the GCs prior to them being seen. And quite often we are the first point of contact following a diagnosis in the family or a sudden death. So that first point of contact is really, really important. And like I said, often lands with the nurse specialists. So particularly with the paediatric team, I'm not going to run through all of those. I'll probably just pick out a few things, but these are all the many things that we do clinically for our families and our patients in the ICC service. You know, the top points there are probably the things that keep us most busy. Some of the initiatives that have come out from our ICC team is this brilliant early warning traffic light system that we create bespoke for patients that are symptomatic, and to alert them when to let us know when things have changed, but bearing in mind what their baseline is. And this is really useful information for them, but also for things like schools and parents, and even A&E departments as well, if they take those in with them, which we encourage. That doesn't replace care plans that we do for schools as well. A lot of our work is based around cascade screening. And we're all very skilled in terms of relaying inheritance risk, patterns and family history taken. One of our main roles, again, is of course translating all that information and all that crazy stuff that you've just heard from Tessa, and being able to explain that to the patients. But what we often find as nurse specialists, that we get some of the myths that we have to debunk, like, well, my son won't have it because my other son had this condition because he was born in September and so was his father. He won't have it, he was born in May. You know, we come across things like that. Oh, he's definitely more like me. So, you know, he's got blonde hair, I've got blonde hair. He won't have long QT syndrome. He just won't have it. And it's quite difficult to say, don't be crazy. So unpicking that type of information, it can, you know, can take some time. And that's why we're here too. Some of the more practical things we do BLS training with families. AEDs and life vests aren't commissioned by the NHS. So it's often up to us to try and help source those through charitable organisations. There was a very young boy who had some horrible out-of-hospital cardiac arrest. Well, they're all horrible, but he did spend quite a bit of time in PICU, and we were trying to get him to gain weight in order to have an ICD fitted, but that was proven pretty long, and the distress that was causing the family and being in PICU for so long was a real problem. So very carefully considered, we sent him home, but with an AED. And we were able to do that because of one of the nurses sourcing a charity, a very small non-profit charity called the Oliver King Foundation. And they came to the hospital and presented him with an AED. And this charity was set up by the father of a boy who died. And it's been his life goal to ensure that all schools have AEDs. But he came and presented it and gave the parents training. So this young lad was able to go home, and I think he's due or had his ICD. I think Leonie might have to confirm that. So things like that we do. We work on behalf of the doctors sometimes in clinics. We will do consultations within consultant-led clinics. We do a lot of referrals, we do a lot of safeguarding. Transition is a huge, huge part of what we do. You'll often find that particularly the paediatric nurses, they probably spend more of their time with the cardiomyopathy patients just because of all the multi-system problems that these children have and management of those. But what we often find is that the children in the inherited arrhythmia service probably give us more problems with regards to the mental impact, the psychological impact of having this condition. And compliance can be really, really tricky because they feel well. Well, I was feeling well, so I didn't take my beta blocker. And then they collapse. So being able to educate and express the importance of taking their medications and be compliant and coming in for their tests is a really important part of what we do. But my colleague Lucy is going to give you a really lovely talk on transition in a moment. So I think, am I on time, Lenny? I don't know where I am.
You've still got some time, don't worry.
Great stuff. So some of the other roles and duties that we do within our nursing team is, you know, we spend a lot of time on education, and that's something that's really, really, really important to us as a team. Not just to patients, we do a lot in terms of resources and literature, and now we're working really hard to make this all digital. Particularly now, a lot of face-to-face consultations don't happen, and we're unable to give them the leaflets and the BHF booklets that we ordinarily did. So we're having to find new, unique ways of doing that. So we've put on patient days previously, but we're also doing virtual coffee mornings now, which have been really well received in our cardiomyopathy service. We do a lot of also healthcare professional teaching. So we go on the wards and we do teaching. A few of us within the team work on teaching on MSc programs, nursing programs. Back in 2014, you can see a poster for it. The nursing team here put on the first ICC nursing study day in the country. And that's been a rolling thing ever since. And now it's gone external, and we also invite allied health professionals. GP awareness is a huge thing for us because we have a lot of problems getting GPs to refer patients into us. We spend a lot of time in trying to educate GPs that things like postpartum cardiomyopathy, there is a genetic and inherited element to it. So you really must try and refer this patient on. And it has been difficult. And it was something that was quite significantly picked up in that heart-to-heart report. And because of that, we've worked with the commissioning here at the Brompton, and now we're able to facilitate service-initiated referrals where we don't need a GP referral. Now, the reason why we have that, but we do reserve that, though, for those patients that I mentioned that are quite urgent. So those that we know, family members that are collapsing and got a risk of an ICC in the family, we want to see them quickly. We can't wait around for a GP. Or where it's been really difficult and the family members just aren't getting that GP to refer them. So we keep that in our back pocket, so to speak. We are a big resource to internal and external healthcare professionals, and hopefully following today, if any of you guys ever need any help or direction, then we certainly would welcome you contact us if you do need any advice. We also accommodate other ICC nurse specialists that come to us to observe our clinics as hopefully, I think, a benchmark of how a really effective ICC team, MDT team works. And then we keep good links with those centres there afterwards. And we do a lot with charitable organisations like BHF and things as well. I gave a talk for the BHF the other day, and the Genetics Information Service BHF nurse came and gave one to the nursing team yesterday also. So that's really important to us. We do a lot of service development. So we've done a lot of patient experience data. We do auditing, we do benchmarking and policy writing in terms of pathways within the service. And then there are other really interesting things that we do as well in terms of networking. An ICC Pan London Nurse Network has just been developed. I think we do our third meeting in January, and that's a really useful forum for us to try and work out how we can share information. Sorry, I've gone back one, haven't I? Merry Christmas, everyone. It's a really helpful way of us trying to establish networks and information sharing, because quite frequently these patients aren't being looked after, or families in one service. And it's really important that information to be able to look after these families as best as we can. So strengthening those links is only going to help families and us. That's a really exciting part of what we're doing at the moment. We're also part of ACHD networks because we appreciate that a lot of these patients are still being looked after by congenital heart disease services. We're also members of the AICC. We're on ESC working groups, and we've got quite a good voice in that in terms of what the nursing experience is with looking after that. And I think that's only going to improve with time too. And we've done lots of speaking and presenting both internationally and nationally. And we do a lot with public relations and media and things as well. But these are all tied on to our role as nurse specialists within the team. But fundamentally, you know, the clinical work that we're doing is core to our role, and being that link between all the different components of the MDT and the ICC service. And, you know, it's a really exciting area to be working in, one that's always developing, but we rely on people external to the trust as well to let us know perhaps what would help them and benefit them in looking after these children in the community too, because with the way that current services and healthcare is working and the NHS long-term plan, we will be relying on other centres to help us with as part of a shared care approach to look after these children and families and adults. So any feedback from you guys would be greatly appreciated. Now, that was a really whistle-stop kind of trip through ICC and the nursing team. Thank you so much. I think my lovely colleague Lucy is going to be speaking in a moment, but I'll hand you over to Leonie. Thank you.
Thank you very much, Bethan, for great overview of the role of the CNS team within the ICC service. And, you know, I can't stress this enough. They're a very important part of the service. And I'm sure all of you would have come across similarly in the role of cardiac nurse specialist within the congenital heart disease team, and it's similarly important in that respect. So any questions for Bethan? Again, you could raise your hand or you could type in the chat function. Okay, so Bethan. There you go, 2 for you.
Sorry, what have I got for me?
Oh, have you not seen it? Oh, you missed it. 1.
Oh, is that my clap?
And another one.
All right, okay. Maybe I did see the first one and I just wanted to.
You wanted to. Now you've got 4. Okay, moving on. The next talk is regarding transition in ICC. Again, just like congenital heart disease, ICC is a lifelong condition, and their care doesn't stop after the age of 16 or 18. So it's important that we take that view as well when we're looking after them within the pediatric setting. And obviously, a very important part of this is transition, going into adult life. So Lucy Green, who's one of our cardiac nurse specialists, pediatric cardiac nurse specialist within the ICC service, is going to talk to you about transition, which she's done a lot of work in within the London area. So thank you, Lucy. I'll hand the floor over to you.
Thank you, Lenny. Can you hear me okay?
Yes, we can.
And can you see my presentation?
Yep.
Brilliant, thank you. Thank you for asking me to talk today on transition in inherited cardiac conditions. I'll try not to keep you too long because I think you've got lunch after me. So I think this leads on quite nicely from Bethan's talk on the nurse specialist team here at the Royal Brompton Hospital and Harefield Trust. I think we all know that transition is important for all patients that we care for. However, I just thought it would be good to go through a few reasons why it can be particularly important, and for us to have individualised transitional care for patients with inherited cardiac conditions. So often the disease process, there can be an increased risk, patients with ICCs in adolescence, or sometimes this can actually be the time that they are diagnosed with an ICC. So unlike the CHD patients who often know from antenatal care or birth and that they have a condition, sometimes patients with ICCs can actually be diagnosed at any point in their life, but sometimes in adolescence. Also, we experience that patients have a lot of psychological impact and sort of need that additional care, knowing that they may be at risk of a sudden death, or they could have potentially had a cardiac arrest or experienced a family member having a cardiac arrest. As they are sort of diagnosed sometimes later on and not from childhood, they may need some additional education and support with coming to terms with their condition or their diagnosis. And a lot of the time they can have influences from family members, so they may not be the only person in their family that has a diagnosis of an inherited arrhythmia or a cardiomyopathy. So that can be troublesome sometimes in one or two ways, because sometimes they may have a parent who's got a particularly bad condition and has had a lot of problems, may have an ICD and be very unwell, and they often think that that potentially is how their life is going to be, and that may not be the case. Or that can work on the other end of the spectrum, and there might be people in their family that are very well and asymptomatic with an ICC, so they feel like they don't need to report symptoms. So a lot of education and care surrounding the family and educating individuals about their condition. So I won't talk to you about our service, because I know you've had an in-depth talk from Bethan about what our service is comprised of and who's involved in that. So just to kind of say that we have a very MDT approach to transitional care and the support from other colleagues, genetic counsellors, psychologists, obviously the consultants, and we have lots of MDT support as well. So what do we offer our patients with an inherited cardiac condition? What transitional care do we offer? So we aim to do a transition consultation, a nurse-led transition consultation with all patients above the age of 12, ideally yearly. And I'll show you an example of what that looks like, the template of what that consultation looks like and what we include in that later on. We document this and we send it to the patients and also to the GP for their record, so they can have that. We have a dedicated ICC adolescent email address that patients can contact us on, and obviously telephone support. A lot of the nurse specialists also have mobiles, so we can communicate with patients via WhatsApp and text message. Often teenagers prefer to communicate in this way. We attend MDTs, and we're lucky that we have a service where we have many colleagues from from a pediatric background and also adult background, so we're able to communicate, and this has really worked well for transition. And then we have dedicated clinics for 16 to 19-year-olds. More recently, we've introduced ICC patient days, which I'll talk to you about, and other sort of components of the transition service. We do nurse-led research, we do some research into the transition service. We're constantly thinking of ways that we can improve it, and working with patients and asking what they think and how they feel, what else they could be supported with during their adolescence. We link in with different charities like Cardiomyopathy UK, the British Heart Foundation, as Bethan was describing. They offer a lot of things like peer-to-peer support. They have young people forums, Facebook groups, things like that we can direct patients to, that really helps. And also, as I said, with the MDT approach in the clinics, we can often link in with like pharmacy or psychology, genetic counselling, things like that, so get the patients to have support from all those different elements. And as I said, we're very lucky at the Royal Brompton and Harefield Hospital, because and in particular in the ICC team, because there's often this notion of transition and transfer, and often patients, when they reach the age of 16 to 18, they're then transferred to another hospital. Well, we're fortunate that doesn't happen, and we actually have a team of nurses that are both paediatric trained and adult trained, and so this makes for a more seamless transitional process, because the patients aren't having to move sites. They're often still seeing some of the same clinicians, especially in our family clinics. They may see the same doctors and nurses from birth until old age. So that works really well for us, and we can communicate and do MDTs together and things like that. So We do joint cover in the clinic, so we aim to have a paediatric trained nurse specialist in the transition clinic, with also alongside an adult nurse specialist as well. Yeah, and we have regular meetings, particularly surrounding complex patients that may have safeguarding concerns as well, with our colleagues. So we get to know all the families pretty well, which is good. So our nurse-led transition consultation that I mentioned earlier in the talk. So as I say, we kind of target patients from 12 upwards, and that's because that's what the NICE guidance for transition for patients states, that we should be offering transitional care and support from 12 years upwards, actually to 25. But we start off from in the paediatric clinics and the family clinics. We will kind of identify the patients that are in this age bracket, and that's across all the ICC patients, and we will offer them a sort of nurse consultation. So during this consultation, we fill out one of these consultation templates. So the aim of the consultation is to firstly get an idea of whether the patient understands their condition, or why they attend the hospital. Sometimes they could be just coming for screening. They may not have a condition, but they may come for screening for an ICC. And some patients understand their condition very well. They have very good knowledge, and may not need any further education or only a little bit of support. But some patients may also not know very much at all about their condition. So we often offer some education, resources, leaflets, information like direction to websites and things like that, and teach them a little bit about their condition. We also feel it's very important to go through different symptoms that they may experience, and what to look out for, and we talk to them about if they have any current symptoms, and then what to do in the event of symptoms. So which kinds of symptoms that they would need to go to A&E for example, obviously if they collapsed or had severe episodes of palpitations, or which symptoms, if they're noticing, they could contact the nurse specialist team or their GP about. So we discuss that. We also talk a little bit about their medications. We know that in adolescence, patients can sometimes be more prone to non-compliance. So we talk about the importance of their medications and why they're prescribed them. We then also talk about a few other sort of lifestyle advice, healthy eating, drugs and alcohol. We talk about contraception, family planning, exercise, college, career choices, all of those subjects. We also ask all patients about their mental health, whether they have low mood or whether they experience any anxiety, and we can direct them to different services if they need any support with their mental health. Many of our patients may have ICDs or pacemakers, so we can talk to them about that and educate them around their ICDs, what to do if they ever experienced a shock. And then we offer the patients the opportunity for their parents to be present if they want to, and then we also encourage them to do one of these consultations without their parents. So we also document how their parents are feeling, if they had any questions about transition. Sometimes they may have some concerns about their child moving through to the adult clinic if it's not in the family clinic that we're meeting them, and we talk to the parents about what this means and how we can support them through that process. And then sometimes we kind of set some objectives for the next clinic. Potentially, if a patient's not been compliant with their medication, or they haven't, picked this up from the GP, we might set some little objectives like that to, things like learn more about your condition, pick up your own prescription, read your own clinic letter, if they don't do these things already. So trying to encourage them to kind of get ready for being in an adult service and in the adult care. So yeah, and then we ask some general questions at the end about if they're a carer, if they're registered with the GP, or if they have any involvement with social care. This is an example of one that's filled in. So they're very individualised depending on the patient and their condition, and we kind of fill this in and this gets sent to the patient and their GP. So we have some dedicated transition clinics as well as the family clinics, and this was kind of launched in April 2016. And the idea of these clinics was that they would provide an environment for patients of a similar age group, so they could interact, and we could offer some further transitional support for the patients while they're in this clinic. Initially, before this was set up, we asked the patients when they would like these clinics to be run, and they expressed that they would like it in school holidays. They didn't want to miss time out of college. They may have exams, things like that. So they run in the school holidays. Typically, as I said before, they're covered by the paediatric and the adult CNS as well as the medical team. This is an opportunity as well to kind of introduce them to the adult medical team. It's in a familiar environment for them. They also have this transition consultation as part of the clinic, as well as their usual tests and investigations. Obviously, it's been a little trickier this year with COVID, and we're thinking about ways to adapt these sort of services, not only from face to face, but also do some virtual forums and webinars, and thinking about virtual clinics for these patients as well. So in 2017, I did myself with my colleagues did a service review of the adolescent clinics to see how we were going, if the patients found them useful. We gave them some of these forms to write down some things that work well for them in relation to the adolescent clinic, and what they would like more of from their transitional care. So the feedback was positive, which was good. They liked it. They felt that the clinic was well organised, which is always good to hear. And they liked the contact with the nurse, which again was good to hear. And they found it helpful to be an environment where they were kind of not with the younger children, because often when some of the teenagers are becoming sort of 14, 15, 16, they may still be in a clinic with very young children and babies. So they really like it when they come into this transition clinic when everybody's kind of the same age as them, and they like the communication and the environment. And the things that they said that they would like more of really was just even more opportunity to meet other patients in a similar situation to them, to have some more talks, and to kind of have some more peer-to-peer support. So following that, we introduced our patient day in 2018, and we managed to secure some funding with the Brompton Fountain to hold this at Chelsea Football Club, which again enticed many of the patients that supported Chelsea, that they liked that environment. They, some of the breakout sessions that we did were in the boxes there at Chelsea Football Club, and we were able to kind of they were able to have an opportunity to interact and do different sessions on different educational lifestyle topics. We also did a session with the parents, so we did breakout sessions where the young people went and did things on alcohol and sexual health, and then the parents had time to kind of talk and discuss between them how they felt about caring for young people with an ICC and them going through the transitional process. And the feedback was good from this day. So we held that again in 2019. Unfortunately, we weren't able to hold a physical patient day this year, but maybe next year, or we were thinking about sort of converting this into a sort of virtual conference potentially. So plans for the future, we continue to want to offer patient days and more opportunity to support our patients who are transitioning. We're always continually reviewing the service and gaining feedback from patients and working in partnership with patients to improve their care within this age range. And also learning from other services. I mean, we've only been running our transitional service formally since 2015/2016. We initially pulled upon a lot of ideas and advice from the CHD services, and we're part of a transition working group at the Royal Brompton Hospital with different respiratory services and asthma, CF, CHD, all the different CNSs, and we're kind of always drawing upon experience from different services. And finally, this year we secured some funding through the KHP partnership to develop our services with the transitional care. So we were really pleased to receive this funding, and we aim to work with the other centres going into the merge with King's College Hospital, Guy's and St Thomas's and the Evelina Children's Hospital to develop transitional care for inherited cardiac conditions, and we will be holding some more focused groups at the Royal Brompton and Harefield, but also across those different hospitals, looking at what patients would like more from their experience of transition. So thank you very much for listening. I hope that was of interest to you, and I'm happy to take any questions.
Thank you, Lucy. Oh, great talk about transition. Any questions for Lucy?
No?
You're saving up the questions for later, I'm sure.
Okay, that's fine. I hope it was.
Thanks very much, Lucy.
No problem. Thank you, Leonie.
Thank you. So we are now just past 1. We're just going to break for a short while, and we'll reconvene after lunch at around 2 o'clock. So again, I'm just going to break you guys up into groups again. So the ones who could access the chat rooms will find yourself being channeled into one. Again, this is all done randomly. So you'll be seeing other people you didn't see earlier on. So it'll be a good way to just get to know each other if you don't already know the people in your group. Okay, so we'll do that now. And the rest are going to stay within this room. If you cannot access the chat rooms, you're going to stay within this room, and you can use this as your chat as well. Again, feel free to pop out, get some lunch, or come back with lunch. Yeah, be entirely flexible. Okay, I'm just going to open the rooms now. Hi, everyone. I hope everyone's had a bit of a break and had some lunch. Can you all hear me?
Yes, we can hear you.
Fantastic. Great.
Yep.
So I'm just going to see. Yes, we're just waiting for the next speaker to come online. So, and in fact, I've just closed the chat rooms, so there'll still be people coming back in. Yes, everyone's back in now. Perfect. So this will be the last half of the afternoon, last third of the afternoon, and we have about 3 talks before we break for an hour of sort of case discussions. Does anybody want to ask anything at this stage? Anything particularly that you wanted to raise? If not, we can obviously have a chat at the end.
Hi, it's Pete Lillisos from Leeds. Really enjoying the study day. Just wanted to clarify something Nitha mentioned during her talk, if I heard it right. Bicuspid aortic valve, did she suggest first degree relative screening? Hello? Hello? I think your audio is, I think you're on mute.
Sorry.
There you are, yeah. So if she suggested patients who have a bicuspid aortic valve, did I hear it right that first degree relatives should all be screened as well? Because that sounds like that would be quite an undertaking.
Well, it is. I think that this. I didn't completely catch that bit of Nitha's talk. Although she did refer to some guidelines that was set out. I don't know if you got a reference for that. It does. There is a genetic inherited familial component to this, and often we do find bicuspid aortic valves in other first degree relatives as well. Clearly, it is quite a fairly common thing that we see, and the logistics of it may not be entirely practical in some services. But I think as much as it's possible, that would be something we aspire to achieve.
So thanks.
Great. I think we've got Professor Daubeny online now.
Hello there.
Can you see and hear us, Piers?
I certainly can, yes.
Fantastic, fantastic.
Can you hear me?
I can see you and I can hear you as well.
Good.
Do you want to see if your Wi-Fi is able to bring up the presentation?
Yes.
I've got it here if you can't.
Yes. Okay. Just 1 second.
So while Professor Daubeny is trying to bring up his talk, I'd just like to introduce him to the group. Piers is one of consultant pediatric and fetal cardiologist here at the Royal Brompton Hospital. He's the lead for the Cardiomyopathy service, and some of you may know him from the BCCA as the president-elect. So he's going to give us an overview of the cardiomyopathies.
Now, let's see if this works. So, do you want to record this?
No.
Thinking about it. I'm just going to go onto my phone and do it that way.
If it doesn't work, I can share from here.
Yes, okay. I've just got a circle that's going round and round at the moment. So not seem to be doing it here, Leonie.
Shall I share it?
Yeah.
Okay, I can do that. Let me just do that from my side. So let me know.
Yeah, I can see half the screen there.
If you can see my screen.
Okay, I can see all of it now.
Perfect.
Good. Okay, so we're good to go?
We're good to go. Oh, okay. Great. Do you have a button up there that says request control?
Yeah.
Can you click on that? I think I can give control over to you. There you go.
Okay, and that will...
I think you can then move it along.
And how do I do that? By clicking or?
Yeah, if you go so down, does it work? An up and down button, does it work? Ah, there. At the bottom left, there are forward buttons. So just below your cursor. Yeah, on the left.
Okay.
Back and
yes,
forth.
There we are.
Try that. Ah, perfect.
Perfect. Okay, good. Let's go. Good. Well, apologies everyone for the technical hiccups, but we've got that going now. Hopefully you can hear me all right. If not, let Leonie know. So we're going to talk about cardiomyopathies today. It's a shame this is over Zoom because it would be nice to welcome you all to the Brompton personally. That needs must. So cardiomyopathies then. There are different classifications of cardiomyopathies depending on which side of the Atlantic you're on. And so Leonie, I can't change slide there. Can you go forward a slide for me, Leonie? So Leonie, can you move me on a slide?
Sorry, let me try that.
Very good. Okay, so this is the European classification then. The previous was the US, and you can see we're going to talk about, if you click on, I see it now. Yeah. Okay, so I'm going to go request control there, Leonie.
Yeah. There you go.
Problem is that that button disappears when that happens.
Oh yeah, very odd. So I don't know. There.
There it is.
Yeah.
Is that so? That's you doing that, was it?
That's me there. Yeah, I'm sorry. I don't know why it doesn't appear when your cursor is there. If you move your cursor up, yeah, seems to have disappeared. Ah,
there
okay.
It is.
There you go.
Okay. Good. Okay, so the major sources of information that we have from for cardiomyopathy are from several big studies. The first one of which I did when I was a fellow in Australia, which is the NACS study, National Australian Childhood Cardiomyopathy Study. This was a study of all types of cardiomyopathy up to the age of 10 years. And it was done from 1987 to 97. And we recruited those children in the late 90s. And there was about 314 cases. Now, you might think that that's quite a difficult job to go and visit all of those cardiac centres. But as a fellow, I did the honourable thing and volunteered. And I thought I was going to get plenty of this. And actually, what I got was plenty of this. So I know every medical records in every major city in Australia. Now, that gave very useful information because it was population-based. The Americans, at a similar time, ran a very big North American registry. This was a group of about 20 centres. So it was not population-based, but it was a much bigger study. And they got about nearly 10 times the amount of cardiomyopathy over a longer period. And those are the centres that they recruited. Finland is also very good for population-based studies because it's a finite population and it's got excellent records and people don't go abroad for treatment. So they also did an earlier study of cardiomyopathy. They did it as idiopathic, which is a bit of a shame because, as you can imagine, over the course of time, we find causes for idiopathic and it gets smaller and smaller. Anyway, that yielded good data. And now Juan Kasky and team and Gabriel Norrish have put together a UK study, and that is also giving excellent data on HCM. So let's start with hypertrophic cardiomyopathy, and this shows the typical features. You can see top left, you can see asymmetric septal hypertrophy. In top right, you can see that there's extremely narrow outflow. I don't know if you can see my cursor, but all the blood's got to come out there between the anterior leaflet of the mitral valve and the septum. So there's systolic anterior motion of the mitral valve. There's an LV outflow tract gradient there, which you can see is a very dynamic shape. That means it's dagger shaped rather than rounded. And those are the typical features of HCM. So there are different definitions, but this is the one from the AHA. Unexplained LV hypertrophy in the absence of another cause or systemic disease of cardiac hypertrophy, and septal dimension greater than 2 standard deviations. Multiple diseases with a common phenotype. And it's about 1 in 500 of adults, so pretty common. In children, we would like to have serial measurements that are greater than 2 standard deviations because there's quite a few babies that have non-specific hypertrophy in the newborn period that then melts away, whether it's gestational diabetes or just general stress. It can produce hypertrophy, so it's got to be persistent. So the annual incidence, as we said, the incidence in the prevalence in adults is 1 in 500, but the annual incidence per 100,000 population is much smaller in children. The PCMR study went up to an older age, but everyone is getting about, in infancy, they're getting about 2 to 3 per 100,000 of population. And presentation, this is a curve from the NACS study showing hypertrophic, unclassified, which is LV non-compaction, predominantly restrictive and dilated cardiomyopathy, and the 50%, the median is coming in at 6 months for HCM. So that is the median of when they present. Same for the HCM, you can see, and same for LV non-compaction, but the restrictives are older. And this data here shows that those that have a family history of HCM, which tend to be the sarcomeric protein group, tend to present older. They tend to present from the age of 10 onwards. And those with no family history of HCM tend to present in infancy. And that is also borne out on the right-hand side panel, which you can also see that that a lot of those in infancy are, for example, Noonan syndrome, inborn errors of metabolism and so forth, and those that are non-syndromic tend to be 12 to 18. So if you just look here at the blue lines, this is the etiology. So there is a group with inborn errors of metabolism. There are some malformation syndromes, for example, Noonan's. There's neuromuscular, for example, Friedreich's ataxia. And then there's some that are just isolated familial cases in infancy. So this is the Brompton panel that we use now. And you can see that we're screening probably 30 or 40 genes. You can see from Gabriel Nolish's study that those are the incidences of those genes that came up. And genotyping now is at the forefront of the management of these patients. So we would do a cardiomyopathy screen as we've always done, but we would do a genetic panel on all of these new patients. We would get our specialist nurses would do a very detailed family history, and we would screen all first degree but not second degree relatives. And we would also do cascade screening if we get a positive genotype. Then in clinic, we would risk stratify. What is the risk of that child dying suddenly before you see them next? You would do that on Holter monitoring and sometimes on loop recorder. We would then give them advice about lifestyle modification, exercise, and so forth. We tend to reserve beta blockade when there's an outflow tract gradient, and when there is a severe outflow tract gradient with symptoms, then we sometimes go for a myomectomy and an ICD if we feel that's indicated, rarely transplant. And so this is from a very nice paper in Circulation Research, which summarizes in a little panel. So if you are switching off, then just take a picture of this, which gives you a nice summary of the symptoms, treatment, and outcomes from HCM. So from our study, which we looked recently at the long-term outcomes, this is the Australian study, 10-year survival is about 80%. Now that's considerably worse than the adult studies of HCM, and the reason for that is there is a very quick drop-off in the first year of life, and that's because those children are often metabolic problems, they're often very sick indeed. If you take those out and just look at the survival for those who've already survived a year, then you get a curve that's virtually identical to the adult survival curves. You do worse if you've got Noonan syndrome and HCM compared to HCM alone. You do worse if you do not have a family history. Those that have a family history in HCM are usually the sarcomeric protein mutations, and they're the ones that present at teenagers. So the young ones are the ones that, the very young infant ones are the ones that do worse, and they have do not have a family history. If you are an infant, as we said, you do worse. And this was also borne out from the UK study, where you can see that in those bottom right panel, those less than a year did worse. And those that were non-syndromic did better. Risk factors for poor outcome. Well, if you've got worse hypertrophy, you do worse. If you're worse, if you've got Noonan's, and you're worse if your fractional shortening starts to deteriorate. Now, if you're older than 16, your risk of sudden death has been very nicely put together with this HCM risk European Society of Cardiology website, and it's extremely useful. You plug in your data and you get what risk there is of sudden cardiac death within the next 5 years. Generally, people say if it's more than 5%, then you put in an ICD. Now, we use this in children who are less than 16. You're not meant to, and it is not necessarily going to work, but it gives you some idea if they were a year older what their risk would be. Juan Casqui's group have looked at this and felt that the ability to discriminate between high and low risk individuals is not so good in those less than 16. So strictly, you should not be using this in children, but it's a useful idea of how to gather together the risk factors. And how do you die? Well, some die of congestive cardiac failure, particularly the infants. Others, when they're older, can die suddenly, as they do from the more adult type of HCM. If you look at this panel here and look at the HCM group, which is a sort of maroon color, there's a small but steady risk of sudden death, but nothing like as high as restrictive or LV non-compaction. So at the most recent follow-up, after about 15 years, half of these patients are well and on no medication. Half are on a beta blocker, a fifth had ICDs in, and about half had LV outflow tract obstruction. So HCM is not one disease. It's a common phenotype with multiple genotypes, and common causes are listed there. We would screen all first-degree relatives, and we would genotype these conditions to individualize treatment and manage first-degree relatives. Your risk of death is highest in the first year of life, about 14%, and then reduces to about 0.4% per year subsequently. And if you survive your first year, then you do well. And it lists the risk factors for poor outcome, and it also states that inborn errors of metabolism do worse than the idiopathic types. So that was a whistle-stop tour of hypertrophic cardiomyopathy. Now moving swiftly on to dilated cardiomyopathy. This panel shows the salient features here. The LV remodels to become spherical rather than bullet-shaped. It can cause annular dilatation and mitral regurgitation, and left atrial pressure goes up, and you get congestive cardiac failure. In the NAC study, and there's a bit of variation in definitions for this condition, we said an ejection fraction less than 45% or fractional shortening in 20% if there were no symptoms. But if there was reduced LV systolic function and symptoms, then it would be, we would allow in higher ejection fractions or pathological evidence of DCM at autopsy. Instance then more in infancy, just under 1 per 100,000 at-risk population. And you've seen this panel already, so this time look at the red curves, the red bars, and you can see neuromuscular disorders are up there, things like Duchenne's, Becker's. There's also myocarditis, as well as inborn errors of metabolism and familial cases. So let's just talk about myocarditis. Multiple causes, but the majority of the causes are the ones we see are viral, usually enterovirus, but other viruses are found. There is a bit of a differential diagnosis problem with this condition in that every time that you get a dilated cardiomyopathy that presents, they're destabilized by something, usually an intercurrent infection. If that's a rhinovirus, is that the cause of their DCM? Is that myocarditis? Well, it's unlikely if it's rhinovirus, but if it was an enterovirus, it probably would be. Make sure that you're dealing with sinus rhythm, that it's a sinus tachya, not an SVT. And furthermore, make sure it's not an ectopic tachycardia, as shown in this slip of this picture of long RP tachycardia, which can masquerade as cardiomyopathy. Then there are other metabolic states where you can have LV dysfunction and tachycardia, and of course, sepsis and others. This is a little simplistic, the difference between DCM and myocarditis. You don't see these differences in all cases. Previously, we would have biopsied and looked for a lymphocytic infiltrate, but now what we're doing is to do early cardiac MRIs, and the MRI doctors tell us that they can definitively make this diagnosis from myocardial edema if the scan is done early enough. So we're now moved to doing that and not biopsying. This is our cardiomyopathy screen that we would put the children through, and we would also do the DCM panel at the Brompton. We are getting about 70% pickup for HCM and probably about 50% pickup for the genetics for DCM. And this is a summary of the symptoms and the treatments, of which you will mostly be familiar. Obviously, general PICU supportive therapy, ventilate if needed. Try to avoid that if possible, unless they absolutely need that. We would go for milrinone and try to avoid adrenaline. Anti-congestion therapies, we would treat arrhythmia where we see it, and anticoagulation. Second line, when the child is a little bit better, we'd start onto oral medication, oral spironolactone, which has got an effect that is beneficial in addition to just the diuretic effect. We would make sure that their vitamin D is adequate after they've had the screen, which includes that. We'd also start them on carnitine, having taken a sample for that. Start them on an ACE inhibitor. Sometimes digoxin. Some hospitals are keener on digoxin than others. If we were struggling to come off the milrinone, we often go on to oral enoxamone and run that for a month or two. And if we're in dire straits, we sometimes add in levosimendan and do that once a week. We'd obviously treat any unresponsive tachycardias with a radiofrequency ablation. Immunoglobulin I mentioned there, that is something we've tended not to do now, but previously we used to do it if we suspected myocarditis. So if things are worsening, then early transplant referral, discuss with the local transplant centre, transfer to them, or you can go for mechanical support, LVAD, ECMO, Berlin heart, etc., or total artificial heart, such as the one we did at the Brompton a couple of years ago, or transplant. So chronic treatment, we would have the child on an ACE inhibitor, typically with diuretics. We would rate control, usually with bisoprolol, sometimes atenolol. If we were on maximal dose, we might add in ivabradine. Sometimes we use digoxin. We have started a few of the older children on Entresto, which is a mixture of a neprilysin inhibitor, sacubitril, and an ARB, valsartan. We would consider anticoagulation, antiarrhythmics, and very, very rarely biventricular pacing. So the outcomes in DCM, this is from the NAC study, 10 years survival is about 60%, and quite a steep initial drop. Those with myocarditis do better. and they tend to survive if they leave hospital. And you may have heard of the 1/3 rule. I was taught that when I was a fellow. 1/3 get better, 1/3 deteriorate and need transplant, and 1/3 remain on medication. Well, that seems to be roughly true. If you forget the medication bit and say 1/3 have either die or are transplanted, and 1/3 have normalized of their left ventricle, and 1/3 have LV dysfunction, then that holds true from sort of 10 to 15 years out. Useful rule of thumb. So risk factors for poor outcome seems to be bimodal. Those who are in the neonatal period do worse, and those older than 5 do worse, as opposed to HCM, where familial cardiomyopathy did better. In DCM, familial cardiomyopathy does worse. And if you have worse function at presentation, you do badly. If you have ongoing bad function, almost by definition, you do worse. So DCM is a common phenotype due to a very heterogeneous group of conditions with that phenotype. Multiple different genotypes, some familial, some metabolic, some myopathy. We again screen all first but not second degree relatives, and we genotype to try to give individualized treatment and management to first degree relatives. And we recommend follow-up in a dedicated ICC clinic in your hospital. So, without pausing for breath, we go on to probably the most interesting of all of them, which is LV non-compaction. So this is a honeycombing of the left ventricle, seen in multi-modalities here. What it is that there is a non-compacted region of the heart. Now, through embryology, all of us go through a non-compaction period of the heart during development, and then it compacts, and you tend to lose the non-compacted area. Some fish, bottom feeders, they keep that non-compaction. Fast fish, like tuna, they are compacted and have coronary arteries. So this is an embryological stage that we go through, and some people have said this might be arrested development, possibly. So what we're talking about is what is the ratio of the compact to the non-compacted area. And if you look at this, there are multiple definitions. The one we tend to use is the ratio of the non-compacted to the compacted region. That's in systole, though we also would always MRI these children to give a second opinion, if you like, and the ratio there is done at the end of diastole, the Peterson formula, and is greater than 2.3. So ballpark, if your non-compacted region is twice or more of the compacted region, then you're likely to be dealing with LV non-compaction. Now, this is a difficult semantic topic, and over the course of time, all of these words have been used, but now what tends to happen is we use the word hypertrabeculation to describe that non-compacted area. Hypertrabeculation, we would say, is a normal thing, and is perhaps 1.5 ratio to 2 to 1. Once it gets more than about 2 to 1, then it's LV non-compaction, which is pathological. So it's a spectrum, hypertrabeculation being normal. Now, there's different subtypes of LV non-compaction. There's a so-called benign type, who never seem to do anything. They have this appearance and they do well. There's a dilated type, which is most common, where the function is reduced. There's a hypertrophic type, which probably is a variant of hypertrophic cardiomyopathy. There's hypertrophic and dilated, that is one where it's hypertrophic, but the function tends to go off, and there's restrictive and biventricular. Now, this condition has an undulating phenotype is the key word. That means that it dips in and out of poor function and good function, and the hypertrophy can change. Incidence, well, the more you look for it, the more you find. So more recent studies have found that the incidence is about just under 10% of all types of cardiomyopathy. Marina Hughes, who's at Papworth now, did a study where she, in Australia, where she looked at it in congenital heart disease, not to do with cardiomyopathy, and found it was present in about 2% of cases. So this shows the fact that this is a spectrum, and those on the left are normal, those on the right are definitely abnormal, those in the middle are up for debate. And so this definition is not great, it's rather arbitrary. The genetics is also quite complicated. That's our panel there, but you can get an X-linked type where there is mutations on of tavasine, which tends to be associated with Bath syndrome and LV non-compaction, and those in conjunction with congenital heart disease, there is notch signaling mutations. The problem with these mutations is that you can find in one family patients with the same mutation, but they have different phenotypes. One might have LV non-compaction, one might have HCM, and one might have DCM. Also bearing in mind that HCM can develop in teenage years and may not be present in infancy, even if you've got a mutation, a sarcomeric mutation. The same can happen to LV non-compaction, so it can develop throughout your childhood. Those children which, sorry, those, are you okay? Yeah. So those, a typical LV non-compaction mutation is a mutation in troponin T. When you put that in transgenic mice and get them to express it, they don't get LV non-compaction, they get DCM. So the whole genetics is murky, to say the least. So treatment, well, you'd fully assess the child with echo and ECG and history and first degree, family tree. You would treat any congestion you see. You may go for anticoagulation. Certainly the adults would. We tend not to. We tend to only anticoagulate when the failure or the ejection fraction is lower, as we would for DCM. We don't think that there's an additional problem from LV non-compaction in childhood. We would risk stratify and put in an ICD if needed. So this is a summary of LV non-compaction in terms of the treatments and symptoms. In adults, they talk about the classic triad of heart failure, ventricular arrhythmia, and systemic embolic events. Well, I agree with the first two in childhood, but the third, as I said, depends on the function, really. If you've got good function, I don't think you get it. Modes of death, failure or sudden. And this is a survival curve showing that it's less than 50% survival at 15 years. This, however, was and is an early cohort. This was 87 to 97 when it was perhaps only the very bad cases that came to our attention. So I'm not quite sure that, I don't think that the outcome is as poor as this if you took a cohort now. And this shows competing states. So the red is alive but poor function. The dotted line is alive with normalization. Some do that, but there's a relentless increase in death and transplant. And this is comparing those with pure dilated cardiomyopathy with those with LV non-compaction and a dilated phenotype. And you can see that the presence of LV non-compaction actually makes the outcome worse, in addition to the actual function of the heart. And the P's 0.08, but on contingency analysis, it was significant. So risk of sudden death is there. You can see it's the green one, and it's ongoing. And then this is interesting in trying to work out whether there was any other way of working out which is the disease state of LV non-compaction from just LV hypertrabeculation. So we looked at using speckle tracking, we looked at the twist of the LV. As you know, the LV should twist when it contracts, and instead we found rigid body rotation. In other words, there was no anti-twist between the apex and the base of the heart. It all rotated altogether. And so that may be a means of working out that there's bad muscle rather than it just being an appearance. Now, so in conclusion, yeah, we agree with that. It's a distinct myocardial phenotype, but again, there's genetic heterogeneity, and distinct genotypes can have phenotypic heterogeneity. There's a fair bit that we don't yet understand about this disease, not least the diagnosis needs clarifying. Risk factors for poor outcome are listed there. Female, that's probably because the Bath's syndrome cases do well. They do worse if you've got no family history. You do worse if your function's going down or if your heart is getting bigger. So finally, restrictive cardiomyopathy. This is probably the worst of all of them. This is the typical Mickey Mouse ears that you see with the large right and left atria and the small, or in fact normal-sized right and left ventricles. You can see top right, there's very tall E waves. You can see that the IVC is dilated with very little respiratory variation. So the definition is really normal volume with biatrial enlargement and impaired filling of a restrictive feature, and normal or near normal systolic function. In the PCMR US study, they had an additional category of restrictive with LV hypertrophy. That's probably a type of HCM. So you get very, very high LA pressures, you get pulmonary hypertension, you can get right heart failure. And if you look at the bottom panel, this is quite rare. This is something like 3 children per 10 million at-risk population every year. So you don't see very much of this. When you do, you will remember every case because they tend to do badly. They present older there. The median presentation is 36 months for restrictive, and this shows the same. Etiology, mostly we don't know, some metabolic. And this is the panel we use at the Brompton. This is probably correct that restrictive and hypertrophic may represent 2 different phenotypes of the same basic sarcomeric disease. They tend to present with cardiac failure. And this is the summary of symptoms and treatments. Early use of diuretics, anticoagulation, antiarrhythmics as needed, ICD, and early consideration of heart transplant, we would refer immediately for heart transplant assessment as soon as we've diagnosed a patient like this. And you can see from this survival curve that those with the solid line who are restrictive do worse than those with HCM and DCM. Risk factors for poor outcome: congestive cardiac failure, reduced function, and if their heart walls are thicker. So least common of the pediatric cardiomyopathy phenotypes, heterogeneous group, different genotypes and secondary causes. We, as I said, would refer early for transplant assessment in this, and we would trace the family histories and look at first-degree relatives, and all of these should be managed in an ICC clinic. So there's a bit of a brief run-through of cardiomyopathies, but hopefully it's given you a good summary, and thank you for your attention, and any questions are welcomed.
Any questions for peers? You could either use the raise your hand function, or you could type it in chat.
Thanks for the talk. That's a really lovely overview of cardiomyopathy. Restricted cardiomyopathy, I've never been quite sure of the medical management. It looks quite limited, really. Is it basically just diuretics and anticoagulation and looking out for arrhythmias rather than peripheral vasodilatation, like with ACE inhibitors and that sort of thing, with you do with a dilated cardiomyopathy?
Yes, I mean, I think you're right. It's a difficult one, really, because if you and anything you do can destabilize. So usually you've got a scenario where you've got a very restrictive LV with good systolic function, but you've got pulmonary hypertension and somewhat off right ventricular function. So it is just that. Diurese, but don't over diurese. I would have on frusemide and spironolactone. If there's function is down a bit, you might try an ACE inhibitor, but you just might destabilize doing that. You might, if the child's having near-death episodes, then sometimes a septal defect helps. Sometimes sildenafil, but we only do that if there is pulmonary muscular overgrowth that is causing spasm. We wouldn't do it purely for this condition because obviously it's not really going to help. So you're very limited. Early transplant referral.
Lovely, thank you.
Ollie.
Yes, hi Professor Leonie. Thank you very much for a lovely presentation. Just a quick one. I haven't really seen any circumstances so far where sort of biopsies have been done in pediatric patients, and I know a lot of this is diagnosed with the blood work and an MRI. What circumstances would there be where you really do push for a sort of histological type diagnosis?
Well, I mean, that's a very interesting question, and you know, traditionally we did used to biopsy a lot more, and the problem with biopsying, say for myocarditis, is it can be patchy, and so you can do a biopsy that's a great piece of muscle, but actually doesn't exclude it. So you'd have to do several biopsies in several parts of the heart to look for myocarditis. So we're relying a lot now on MRI diagnosis. We do sometimes have diagnostic quandaries on the left side of the heart in HCM, for example, whether something is a severe subaortic stenosis or whether it's an HCM. And biopsying in those circumstances during the surgery is sometimes helpful. If you get myocardial disarray, then it's more likely to be HCM, for example. But it's much rarer now that we do this. We tend to use skeletal muscle biopsies if we are interested in the metabolics of a child, and that's a much easier target, and we can get very good respiratory complex respiratory chain analyses on skeletal muscle biopsies.
Lovely, thank you.
Any other questions? Well, you're all very welcome to come and sit in on our cardiomyopathy clinic at the Brompton if you're interested in seeing how we do things. We always welcome visitors, so anyone's welcome.
Great, thank you, Piers, for a great overview of all the cardiomyopathies. Mammoth task within 40 minutes. So thank you. We're going to move on to our genetic counselors. So our next two talks will be given by our genetics counselor, Ellie Quinn and Samantha Mason. So Ellie's probably going to start off. Oh, there you go. Here she comes. So really talking to us, again, focusing on the multidisciplinary team, focusing on the role of genetics counselors within the group. So Ellie, over to you.
Hi, Leonie. Thank you for inviting me to talk today. So let me just put up my slides. I'll turn off my camera. It's being a bit slow. Bear with me. I'm going to do is start by explaining what a genetic counsellor is and what we do, and break that down into the main components of our role. So what we initially do when we meet with patients, which is gathering information really and trying to piece together the pieces of the puzzle and understand what's going on in a family. Education. So talking about genetics can be quite complicated and difficult for patients to understand, and so it's really important that we convey information in a way that's easy for them to understand and also pass the information on to relatives. So how we educate people and convey information about genetics. I'll talk a bit about consent and in particular consent for a genetic test and how that is obtained. We can review some of the psychosocial aspects of genetic testing and how that might impact on our work, and also some ethical considerations as well when we are working with families with inherited conditions. And I thought I'd finish off by talking about some of the common misconceptions that we have when we're working in clinic, we come across, and sort of addressing some of those with you. So firstly, what is a genetic counsellor? So most of us have either an academic or a nursing background, so we're not usually doctors. We usually begin as a nurse or training within sciences, biology, psychology and things like that. And there is a master's program where you can train as a genetic counsellor over a period of 2 years, or recently the scientific training program's been put together for genomic counselling. So that's something that's just started over the past few years. So usually genetic counsellors are based within a genetic service, and there are regional genetic services based throughout the UK. So patients can access services that are local to them. But we're starting to see a transition now, and there's sort of a real movement within the NHS to mainstream genetic testing. So rather than a patient having to go to a regional genetic service for their testing, the testing can be done within their team of wherever they're seen. So for example, we work within cardiology team. So I'm not based in a genetic service, but actually within cardiology. So that really means that there is a bit more emphasis on having genetic knowledge within the cardiology team, and we're not outsourcing everything to genetics. So that's why this sort of training is really important. So let's start with a bit of information gathering. So we usually start by drawing out a family tree of a patient. So you've probably seen one of these before. The circles are ladies and the squares are men. And we're just trying to get a picture of who is in the family and what is their health status. So I've put an arrow there to Nina to show that she's the person we initially were evaluating for a heart condition. And we can see that she has 3 children who are being brought in for screening. So we want to gather a bit more information about the family. So when we're thinking about Nina, we want to know exactly what her diagnosis is and maybe a few more details about the diagnosis. It can be really useful to know which hospital she's seen at so we can request that information, and also whether she's had any genetic testing done already, because that might be useful for her children. And then, sorry, I had a bit of feedback there on my microphone. And then we're just looking here at Nina's dad. So she tells us that he passed away suddenly at age 40, but she doesn't have a lot of details about that. So we really want to know what the circumstances were around his death and whether he had a post-mortem investigation after he passed away suddenly. And also, we're thinking about the wider family as well. So although we've been referred Nina's children, we're thinking about other family members and check whether they've also been referred for their heart checks. So we want to find out a bit more about her brother Michael as well. So Nina gives us a copy of her clinic letter, which turns out she's been seen at Guy's Hospital, and that confirms that she has a diagnosis of hypertrophic cardiomyopathy. So that's good because it means we know what kind of screening we want to do for her children. Nina speaks to her mum, Wendy, and she has some documentation of her late husband's post-mortem, and we can see that he actually had a post-mortem after he died, and he also had hypertrophic cardiomyopathy. Nina actually had genetic testing at Guy's Hospital, so we request a copy of the report, and we can see that she's been found to have a pathogenic mutation in MYBPC3. And then Nina gets in touch with her brother and checks whether he's ever had any heart checks, and he says he hasn't, so she can encourage him to go to his GP and get a referral. So we can add all this information onto the family tree. So Nina is seen at Guy's. We have genetic information here. We know what the diagnosis is. And so we know a bit more about what we can offer to her children when they come in. So her 3 children, Ben, Fred and Tilly, come into our service and we give them an ECG and an echocardiogram, and all of them have normal test results. So that's really reassuring to the family. After these scans, the genetic counsellor is asked to meet with the family to talk about genetic testing. So because we have a mutation within Nina, we know the gene that's caused her hypertrophic cardiomyopathy, we can offer what we call a predictive test to her children. So we can essentially see if they have that mutation themselves. If they do, we would continue to give them regular ECGs and echoes. And if they don't, they can be discharged. So that's an option that's there for them and we can discuss with them. So we know that there's a 50% chance for each of her children that they've inherited this particular gene mutation. So we're meeting with her 3 children, and we really need to get a bit of information about what they understand is going on at their visit. We want to know if they know why they're being seen. Do they know anything about the particular heart condition that their mum has? Do they know that this is a genetic condition that could be passed on to them, and do they know what the risk is for them? So we've got lots of different ages. Probably Ben has done genetics at school, but probably Tilly hasn't. So it's really, it can be challenging to try and tailor information when meeting with sort of multiple members of the family and trying to understand what their understanding is and trying to convey that information in a way to them that they can understand. So say they wanted to have a genetic test, we would need to discuss consent with them. And at the moment, anyone who has capacity and their age over 16 can consent to genetic testing. And indeed, anyone under 16 who's considered Gillick competent can consent as well. If they're not Gillick competent, their parent can consent on behalf of them, and we can also get assent from the child. So it's good practice to also check that the child wants to have the testing done, even if their understanding isn't what we would call Gillick competent. If a patient is deceased and we're going to do genetic testing on their sample, we would get consent from their next of kin to do that. And if we have an adult who is lacking in capacity, we can consult with a carer or someone involved in their welfare before proceeding with the testing. So when we meet with the children and talk about genetic testing, we present it as a choice. So it's not something they have to have. And many young people in this position decide that they don't want to have a genetic test at this point. It might just not be the right time for them. And different individuals. We speak to Ben and he says that he doesn't really want to have a test at the moment. He's kind of got a lot of other things going on in terms of his exams and schooling, and he doesn't want to have a genetic test at this point, and that's completely fine. He's able to make that decision. We've done his heart scans, everything's normal, so we can just keep him under screening. Fred tells us that he wants to have the genetic test, but he says it's because his mum wants to have it, him to have it. So that's a little bit more tricky because we do want Fred to be making his own decision, even if it would be his mum who would be doing the consent for him. So it's about unpicking whether Fred himself wants to have the testing, and it can be really tricky because he may not fully understand what we're doing, however much we try to explain it to him in a way that's accessible to him. And often children want to do what their parents want them to do, and parents can often be vocal about what they want for their child. So it's about unpicking that and making sure we're doing the right thing for Fred at this point. And Tilly just tells us that she doesn't know at the moment. So we have to sort of gauge at this point whether we should do a test for her or we should maybe wait until a point where she has a few more thoughts about that. So things can get a little bit more complicated, and this has all been quite straightforward so far, but sometimes genetic counsellors can get involved in quite difficult situations, and things that seem straightforward at first can suddenly become very complicated. So in this particular scenario, Nina, the parent of these 3 children, sends the children off with their dad, and she asks if she can speak with the genetic counsellor privately. And she explains to the genetic counsellor that Tilly was actually born using an egg donor, but they haven't told Tilly or her brothers because they don't want her to feel that she's not as much part of the family as they are. So this is a really difficult situation because Tilly has essentially come in and had all of these heart scans when she doesn't need to because she's not genetically related to Nina, her mum. But the reason Nina has brought her in is because she wants to keep up this appearance that she is related to her mum. And she kind of doesn't want the children to notice that anything's different with Tilly. So it's a really difficult situation because we've spoken to Tilly about genetic testing. And if we did a genetic test for Tilly, we know it's going to be negative because she's not related to her mum. But that test in itself wouldn't reveal the status that she was born via an egg donor. In normal practice, we usually recommend that parents tell their child that they're born from a donor early on so it becomes a normal part of their identity. But this isn't always the case, and parents have lots of different reasons why they keep this information from their children at certain points. So it can be really difficult trying to manage a child's healthcare whilst also maintaining the balance within the family and whatever they've
Have we lost Ellie?
Yeah, I can't hear anything.
Ellie, we can't hear you.
She's got disconnected.
Yeah, Wi-Fi issues. If you bear with us, I'll get her back on. 2 seconds.
Hi, sorry, did I disconnect?
Yeah.
Did you get to, were you on my egg donor scenario?
Yes, we found out about the egg donor, but we lost you shortly after.
Okay, I'll go back to that. Sorry, I think my don't know if my internet went down or something. All right. Okay, can you see me okay?
Yes, we can.
Fantastic. So yeah, so hopefully you've heard my scenario about the revelation that Tilly was born via an egg donor, and we now have a dilemma of where we have a secret within the family, and essentially the parents have brought the child in for testing that she doesn't really need, and what we should do in that situation. So we would usually take that to a team meeting, because there's no guidance on these sort of scenarios. We need to come to a consensus on what would be the right thing to do in this particular scenario. Okay, so I thought we would go through a couple of common misconceptions that come up in clinic, just because I think it might be useful if you have certain questions or people ask you these things in clinic. And these are misconceptions I've had from patients, but also from doctors as well. So it's really common things that do come up. So I have quite a lot of patients who say to me that they don't want to have a genetic test because their doctor has told them that they won't be able to get life insurance if they have a genetic test. And essentially, this is wrong. So if you do not have a diagnosis of an ICC such as cardiomyopathy, you do not have to give an insurance company your genetic results. This is in the UK, we have a special agreement that you don't need to tell them your results. If you were then diagnosed with cardiomyopathy, you would need to tell them because that's sort of part of your actual medical history, but the genetic results are protected from insurance companies. And we hope that agreement will go on for many years. It's been going on for years that they can't do that. Okay, another common misconception we get is patients tend to draw meaning from what they've seen in their family. And that completely makes sense because they want to take control of the situation and understand what to expect. So just by chance, we can often see that all the men in the family have cardiomyopathy and none of the women, or the other way around. But this is just by chance, essentially, that this can happen. We would usually expect the condition to affect both men and women. It's not sex linked in any way. In a rare cases, we do have genes that are carried on the X chromosome that can cause cardiomyopathy. And so this means these conditions can affect men more severely, but women can also be affected. So in rare occasions, it can be linked to gender, but usually it's a condition that can affect both genders. So another really common one from patients, my dad has cardiomyopathy, but I look like my mum, so I won't get it. Unfortunately, we do get half of our genes from mum and half from our dad. So even if we look just like our mum and have all of her characteristics, we've got 50% of dad's genes. So the risk is 50% for all first degree relatives of someone with a known gene mutation. This is a tricky one. So quite a lot of time there is concern about cardiomyopathy skipping a generation within a family. So it's kind of true. A faulty gene or a gene mutation cannot skip a generation. However, the condition exhibits what we call incomplete penetrance. So some people who have the faulty gene don't manifest cardiomyopathy, or they do so in a milder way or later in life. So the condition can appear to skip a generation when they then pass on the faulty gene to one of their children who goes on to develop the condition. But the gene itself cannot skip a generation. And another sort of hope for the future, really, sometimes people think that if we can find the gene that's caused their condition, that we can fix it. And unfortunately, that is not a simple fix at the moment. So we have seen in research settings, a team in China did gene editing on an embryo, and they corrected a mutation that caused cardiomyopathy in the embryos. but we can't do this in our patients. And at the moment, the main promising target is to sort of use drug treatments to target the exact molecular pathway that can cause these conditions, rather than editing the genes themselves. Okay, so that was my talk. Thank you all for listening, and just let me know if you have any questions.
Fantastic. Thank you, Ellie, and right on time as well.
Even with my technical hitch.
Any questions for Ellie from the floor? Okay, I don't see any hands. And I don't see any messages. Great. Shall move on. Thank you very much, Ellie, for just sort of describing sort of the things that you do in the context of ICC service. So thank you very much. Next, we're moving on to Samantha Mason, who's one of our other genetics counsellor here at the Royal Brompton Hospital, and she's going to focus a little bit more about pre-implantation genetic diagnosis, and Nitha alluded to that earlier on, and so and she's going to talk to you really about the PIGD in the UK and within the constraints of NHS and how it works on a day-to-day basis. So thank you, Samantha.
Thanks, Leonie, for inviting me, and thanks, Ellie, for a great introduction to what we do as genetic counsellors. Let's just hope this works. Sharing my screen. I hope everyone can see this. Is it all working?
Yep, we can see it.
Excellent. Just move that. Okay, so family planning options. So I've changed the, just to start off with, I've changed the talk slightly. Sorry, Leonie. You did ask me to talk about pre-implantation genetic diagnosis, which I definitely will be doing. But I thought it was really good possibly to go over all of the family planning options for someone with a genetic condition, just because PGD isn't the only one. And I think it's a really good idea to have all of the options in the back of your mind. So currently the options are available, obviously PGD, we've spoken about that. Another one is prenatal testing, which I'll talk a bit about. And of course, I think it's also worth noting that another option is just to have children naturally, and then we can test them when they're born, when they're children and things like that as well. So having children naturally is definitely an option available for patients, you know, because these two other routes to go down are quite difficult routes and have their own pros and cons about them. So just going into, and just before I spoke as well, I've just put this slide in just to reiterate that most of the cardiology genes that we talk about and conditions are autosomal dominant. So we're only looking for one faulty gene, and there's a 50-50 chance of passing it on. Of course, as you know, Tessa spoke about earlier in the day, there are definitely excellent conditions like Duchenne muscular dystrophy and mitochondrial inheritance, and with the arrhythmias, we definitely have autosomal recessive inheritance as well. So those obviously skew when we're talking about, you know, the chances of a healthy baby, skew those, you know, either maybe 1 in 4 chance, or, you know, depends if it's a boy or a girl or things like that. But for the most part, we generally speak about autosomal dominant conditions and things like that. So that's what really I'll be focusing on today. So just a bit about pre-implantation genetic diagnosis. I usually describe it to patients as IVF with an extra step. So they have to undertake the whole IVF process, and then there's a little bit more to do in the background. So it does take a really long time. So, you know, first they'll talk to someone like myself or someone like Dr. Homfray, so a genetic counsellor or a geneticist. They then have to get a referral to a PGD centre where they'll talk to more people, more doctors, more genetic counsellors, and have a really in-depth discussion about what is involved with IVF and things like that, and what they have to go through. There'll be a lot of paperwork to go through in terms of checking that their genetic result is the right genetic result. Has it been done at a right centre? Can we track it through the family and things like that? Then they'll have to obviously have their blood tests and scans. The semen will be analysed. Then we'll start, ovarian stimulation, egg collection, and that's all before we get to, fertilisation of the embryo. And then that's where kind of the difference is at that point. So the extra step, as I like to describe it to patients, is kind of this step. It's we grow the embryo until it's at about day 5, and then we take a few cells out of the embryo and screen them for the genetic condition that we're looking for. And so that can be done in a couple of different ways that I know of. One that is regularly done in the NHS because it's a faster option is something called chromosome mapping, which I can go into more detail. I've chosen not to go into detail about that just for the interests of time today. But it's basically, you've got to just map the chromosomes through a family. So you often need several family members. And the reason we do that is because we can do that with everyone, because the other option is a single gene test, which takes months to develop. It takes time, it takes money to develop that unique test for that specific genetic change that's found in that family. So that's why we often go down chromosome mapping route in terms of NHS and things like that. If you wanted me to speak more about that, and if we have time at the end, I'm happy to go through that in a bit more detail. So who can access PGD? And this is mostly, I'm talking about the NHS. I think it's also worth noting that they need to have a confirmed genetic diagnosis. So often when we do genetic testing, we either will get back, yes, this is a pathogenic result. We know it's definitely causing this disease. We also get back lots of things called variants of uncertain significance. So these are variants that are kind of a little bit of column A, a little bit of column B. There's some evidence that it causes disease, but not enough for us to be really sure that this is the underlying cause for someone's cardiac problem. And so for obvious reasons, we can't use that for PGD. So if we do a genetic test in someone and we find a variant of uncertain significance, they can't access these options because we're not really sure that this genetic change is causing the disease in them, and we need more evidence and more time usually. So that can be really devastating for patients to hear, because often if they feel very strongly about this, they want options and things like that. So it can be really devastating for them to hear that actually they can't access any of these options because we don't have a confirmed genetic diagnosis of their condition. So that's a really important point, I think, to stress to patients. And in the if you were referring your patient to the NHS for pre-implantation genetic diagnosis, there are a lot of really strict criteria because obviously they're trying to maximize their chances of this working. So women have to be younger than 40 years. A woman must have a BMI over 19 and under 30. They must be non-smokers and all of these things. So they'll ask you all of these things when you do a referral to them. There's usually a form you have to fill out, and it will ask them all of these things. So it's really good in a consult with someone talking about PGD just to go through all of these things, because say if a woman is over 40, she's not going to be accepted, or if she's maybe overweight or underweight or something like that, instantly you'll know that they won't be accepted. And it might just be if they're overweight, you need to lose a little bit of weight before we can think about this, just because there are restrictions. If they can also go down the private route. They don't have to address these criteria then, because they'll be paying for it themselves. I think the quote at the moment is around £12,000 for doing all of this. Of course, that could be more, it could be less. It depends on how many rounds of treatments how many rounds of IVF and things like that they need to undertake, which obviously we don't know until they fall pregnant. So we don't know how many they'll need and things like that. And maybe they do have underlying fertility problems that they weren't aware of, and all of these kind of things come into it. So just going over the pros and cons of PGD. The pros is you are guaranteed a healthy baby. I say guaranteed, obviously other things can go wrong. We still encourage you to have your first trimester screen and everything like that. But in terms of this specific genetic variant, you are guaranteed to have a healthy baby. You don't have to undertake any terminations, which when I go into the next option, you'll see why I've said that. The cons are, of course, it is really expensive. For most couples, it's out of their price range when we discuss it with them. It's really great that the NHS does cover some rounds, but they only do it for one healthy baby, and it is only for eligible couples. So they only have 3 rounds that might not result in a baby, and it's also only for one child. So if a couple wants another child, they would either have to fund it themselves or go about having a child in a different way. It also, if they have a child from a previous, if they've already had a child before, you know, the condition came out, or before they knew there was a genetic diagnosis, and that child does not carry this genetic condition, if we've done genetic testing on the healthy child, they won't be covered under the NHS for PGD, because they already technically have their healthy baby, so that they won't be covered as well. So it is quite difficult. It's really time consuming. It takes around 1 to 2 years to conceive. It takes so much time because it takes 6 months to a year, as I said, to do all of that paperwork in terms of tracking down, you know, they have to wait for an appointment, they have to then track down all the results of everyone, we have to make sure we have a lab who's happy to do the testing and things like that. So it just, the paperwork takes a really long time, and then obviously all of the treatments just take a long time. So often we encourage people to come in early. We say, even if you're just kind of thinking about it in the back of your mind about starting this, we say you need to start early, kind of a couple of years before you'd actually want a baby, just because it does take a really long time to get all of these things happening. Of course, another con is it might not result in a pregnancy. As I said before, the NHS only covers 3 rounds. That doesn't guarantee a pregnancy. Also, you know, if they decide to self-fund, it still doesn't result in a pregnancy, just because they're a couple undergoing IVF and they have no fertility problems. Unfortunately, doesn't increase their chance of conceiving and having a baby, if that makes sense, compared to people undergoing IVF for fertility problems. They all get the same, you know, 30% chance of falling pregnant. So that's another thing to take into consideration. Another con is it's really physically and emotionally difficult to undertake. So thinking about the psychological things that could happen. So, you know, it's quite tough, and it's especially tough on the woman. And I say that because they have to undergo all the injections, they get flooded with hormones. You know, you kind of get excited around the egg implantation day, the embryo implantation day, sorry. And then it can be a bit of a downfall and things like that if obviously you don't fall pregnant. That's quite disappointing, and so you kind of you go through those highs and lows every time that happens. So it's quite a tough thing to undertake, I think, and that's worth to consider. And of course, there's the risk to the woman that she could have multiple pregnancies. As we know, things are getting stimulated in there, so embryos can split and things like that. And she's also at risk of ovarian hyperstimulation syndrome by all of these drugs. So those are kind of the cons around that. So just going on to prenatal diagnosis, there are, I guess, 2 different options, but they happen in the same kind of way, and I hope you've already got a good background in these. One is chorionic villi sampling, or CVS as we always call it, and the other is amniocentesis. It's a needle through the belly, so it's an invasive procedure, and we often recommend CVS because even though it takes a sample of placenta, because it can be done earlier. We can do it at 11 weeks. And the earlier we do it, obviously, the better, because it gives women more termination options if they do have to go down that route. So we often encourage, if they want to go down this kind of route, to contact us as soon as they fall pregnant, as soon as they know they're pregnant, you know, at the 6-week mark, even that early. And then we can get everything in line in terms of booking them their CBS as early as possible and lining up the lab with everything, so that it can all happen really quickly. So, you know, at 11 weeks, we could take a sample of placenta, and you know, a few days later, we could have the result back. We can have a really quick turnaround time, and we'd only be offering them this if they wanted to go ahead with, if they would terminate a pregnancy based on this result. We would not be offering them, you know, just to see if baby had it or not. We would wait for baby to be born in that case. So this is only if they're viewing to terminate the pregnancy based on if the child carries this genetic disorder or not. So the pros and cons of it are: pros, you can fall pregnant quickly. If you want to undertake this, you can fall pregnant, you know, as quickly as nature intends. You can undertake many rounds. You can have multiple children using this method. So this could be another method if someone had a baby with PGD and still didn't want to pass on their genetic disorder. They could then maybe do something like this for another child. Anyone can access it. There's kind of no restrictions around it, like as in PGD had weight restrictions and age and things like that. It's covered by the NHS. We could also find other genetic abnormalities in terms of we're testing the placenta. We might do just an array as well, just to check that baby's normal and things like that, so we can pick up other things if there's something else we're worried about. Obviously, the cons are it's an invasive procedure and it carries with it the 1% risk of miscarriage. If a couple has been trying for many, many years to get pregnant, it's often a precious pregnancy and they probably won't want to talk about terminating the pregnancy. Of course, another con is you have to undertake a termination if the baby is a gene carrier. That's obviously emotionally difficult for a woman, and it's difficult for the family. And it's, as I've said, underneath it's emotionally taxing. The whole thing is quite hard. And you know, after several, if you're having to terminate several pregnancies, that's really tough on a woman, especially if we're looking at some conditions where there's 2 genes involved and things like that, and the chances of having a normal baby are less than 50%. It can be quite tough. And of course, this also may not result in a baby. We might keep testing and find that every time the fetus has the genetic abnormality, so it may not result in a baby, or they may just go down, we'll just have it with the genetic disorder. So I think it would be good to talk about when to have these discussions, because I think it's overlooked a little bit. So I've noticed when I'm giving parents the results, because often the child has received the result. You know, they've got hypertrophic cardiomyopathy, or they've got an arrhythmia disorder. That's been the diagnosis, and it's not till several months later we might find the genetic diagnosis. So at least they've had time for the clinical diagnosis to set in, and this is kind of a confirmatory. Sometimes the genetic test, you know, really confirms and helps us look at the other family. But I think it's really important when giving back those genetic results to tell them at the time, tell parents at the time, that, you know, in the future, come by and talk to us. There are family planning options available, and very, very briefly just going over what they are if they're interested. And I've found parents find that really useful, because I think one of their concerns and one of their worries at the back of their mind is that their child, you know, will choose not to have children, or will feel like they can't have children based on their heart condition and not wanting to pass it on, and things like that. So I've often found that they're quite relieved to find out that there are options available if their child in the future doesn't want to pass on this condition. So I think it's really useful to mention it then, for relief for the parents. I think another time it's really useful to mention, and I usually say to the parents, let's have a proper chat when your child is a teenager. And why we say teenager, maybe not waiting until they're adults, is accidents do happen, as we all know. And I think as well, it's really good to let teens know. I know they probably won't talk back to you. It can be a difficult conversation to get something back from them, but they will take it in. And then it's good for them to know before they start entering relationships and things like that, that they have an option available if they want to have children in the future. That's come up in some pediatric days. I know some of the girls have come back and said, you know, someone raised a question and they thought they couldn't have children because they didn't know there were options available for them. So sometimes, you know, if they don't know that these options are available, they think they can't have children because they don't want to pass these conditions on. So I think it's really good before they enter relationships and get into their adult years that they can have something at the back of their mind that if they meet the one, they can they know that something's available and can have a more in-depth discussion with someone about it, and things like that. So I think that's a really good time to discuss these things with them. And then, of course, when they're planning a family, really going over in detail about these options and the practicality of pursuing these options, of course, would be a perfect time. And they usually bring it up with you, and it's usually a few years in advance of them actually thinking about it. But as I said, it's really good to get the ball through any of these options. It just takes time. So the practicalities for you guys are, what are the next steps for your patients if they decide to? Confirming that she's fit enough to go ahead with pregnancy, because obviously if she's not, then the PGD will not be pursued and things like that. So that's something that you'll probably be asked for if it's your patient that's been referred on for PGD. So I think that's all. Thanks so much for listening. That was a real whistle-stop tour of everything. I tried to keep it short and sweet and to the point, as I know it's getting late in the afternoon and you've